Again, good morning and welcome to the Network for Social Work Management Policy Fellows Program virtual presentations. I'm Rain Arndt-Couch, co-administrator of the Policy Fellows Program, and all of us here at the network are so pleased to host 2 days of webinars highlighting the work of our truly phenomenal group of 2020 and 2021 Policy Fellows. We're so glad that you could join us today. To kick things off, we'd love to know who's here with us today and where you're from. So if you could add that to the chat, again, we'd love to see who's here participating and supporting our fellows. Feel free to use the chat function. However, for questions and answers, and you'll hear this repeated a couple of times, please use the Q&A function. Welcome, Silas. Thanks for joining us. Hi, Ian. Wonderful, thank you. So to truly kick things off, I'd now like to introduce Dr. Lakia Cherry, CEO of the Network for Social Work Management, to provide some opening remarks.
Thank you, Rain. So good morning and welcome, everyone. We truly appreciate your support of our Policy Fellows in addition to this program. I'm Lakia Cherry, the CEO of the Network for Social Work Management. If you are new to our organization, it's an organization that started as an association over 36 years ago that is dedicated to strengthening social work leadership and health and human services. Over 5 years ago, we started this Policy Fellows program because we felt that social workers should be at the forefront of policy. Since then, we've been fortunate to have over 50 fellows from throughout the US experience this program. This is a competitive 8 to 9 month program where fellows apply with a policy area of interest, and then they're matched if accepted to a skilled mentor from throughout the country. Over the 8 to 9 months, they have an opportunity to focus on that policy area of interest with the guidance of their mentor and the support of their cohort. Our mentors are all volunteers, so I'd like to take the opportunity to thank all of them for their time, their contributions, and their dedication to our fellows, in addition to our organization, the Network for Social Work Management. This year, we tried something new. That is, we started our Policy Fellow Administrators. So you just heard from Rain Arndt-Couch, and soon you'll hear from Dennis Boyd. These are 2 of our former Policy Fellows who believed in the program and wanted to give back. And so this year, they spent many hours dedicating themselves as policy administrators and really taking time to help implement this program. So I'd like to extend sincere gratitude to Dennis and Rain for all of your time and contributions to this program. Next, I'd like to thank the New York Community Trust. This program would not be possible without the support of our funder, the New York Community Trust. If you're familiar with the New York Community Trust, they fund a lot of social work initiatives, and for many years, they have supported this policy fellowship. In addition to that, I would like to thank our fellows. You all, in the midst of a pandemic and so many things going on in our world with your respective jobs and educational programs, many of you dedicated yourselves and committed to this work, which was not easy. And so I'm so grateful for your time, your attention, and your commitment as change makers to improving our world. So congratulations to all of you. To our attendees, have a great time. We encourage you to comment in the chat, to outreach to our fellows, to network with each other. And with that, thank you again, welcome. And I'm proud to turn it over to Dennis Boyd.
Thank you, Dr. Cherry. Welcome, everyone. Welcome. We are so glad to have you. The lineup is fantastic. You're in for a special treat with the presentations that you're about to see. So first up, I want to introduce our first fellow who will actually be getting us started for the day. And there's a lot that can be said. And as we get ready to move into her presentation, I want to remind you to use the Q&A if you have questions to ensure that any questions that you may have get fielded. So I just want to remind you, use the chat. to use the Q&A to put your questions. And first up, we have Haley Ingersoll.
Hi, everybody. I'm just going to swap my display here quick so you can see this properly. All right, thank you so much. So I'm really happy to be kicking this off. My name's Haley Ingersoll, and I'm super excited to be sharing what I've been working on, but even more so to kick back after this and see all of the phenomenal work that my peers have been putting into this process. So be sure to stick around for those. As a quick overview of what I'm going to be discussing today, I want to share some insights from my role as a health experience research consultant, a brief discussion on healthcare fragmentation and potential solutions, the case for social work values in health policy, as well as the future actions needed to improve the entire healthcare spectrum in the US. So without further ado, I'll get into my remarks for today. As a bit of background on me, over the past several years, I've served as a patient advocate, partnering alongside folks with chronic or life-threatening illnesses, supported qualitative patient narrative research and dissemination that I actually recently presented at the Network for Social Work Management Forward Thinking Summit, and have helped provide supplemental research to a state senator on surprise billing legislation. Throughout my time in these roles, it became apparent to me that clients regularly encountered common barriers, and these barriers often came from upstream: denied insurance claims, costly prescriptions, having junk plans with subpar coverage, and surprise medical bills from providers who are out of network. Perhaps you or someone you know has come across similar issues. Know that you're not alone in that. Currently, as many as 1 in 5 individuals will receive a surprise medical bill, which occurs when a person receives care at an out-of-network facility or sees a provider who is out of their insurance network. Common instances of this include emergency room visits, diversion or ambulance transports from an in-network facility to an out-of-network facility, or, as I said, obtaining care from a specialist who's not contracted within the care recipient's network. Anesthesiology is a common culprit for that. And getting through relatively unscathed can look a whole lot like this board game on the screen. Nobody really knows the rules, and sometimes it feels like you're using pieces from the wrong game, and altogether it's just confusing and difficult to navigate. And it's important to note that these challenges are not a result of individual shortcomings. We're taught to trust that the care that we receive is provided in our best interest. Yet there's often questionable strings attached, and many feel that they cannot risk a high medical bill unless survival absolutely depends on it. One mother was advised by poison control to take her child in after ingesting an unknown amount of Dramamine, and instead they opted to wait in the parking lot outside of the emergency room, watching The Little Mermaid, hoping things would subside, but knowing that in the event care was absolutely necessary, they could rush in. But it was that serious that they weren't sure they could risk the high medical bill. It's the mark of a broken system that parents must weigh their child's survival with the cost of care, and that another person's final words are ones of distress about how their medical bills are going to be paid. Needless to say, the process of obtaining and utilizing healthcare coverage is convoluted and might look a little bit like this laser maze on the screen. Utilizing, even for those who are attuned to the pitfalls of it too. Between navigating the marketplace, having insurance tied to one's employment, finding the right amount of coverage, or ensuring all providers fall within a respective network, there's a lot to get right. Not to mention, you might not have the energy or wherewithal to do that if you're experiencing a chronic illness or you're concerned for a loved one's well-being. And this is all because the US healthcare system is a complex patchwork. Apologies for the corny image, but hopefully that helps it stick. And this is due in part to the divide between private and public insurance and an increasingly profit-focused business model. Referred to as an epidemic of profit-driven care, the convolution and fragmentation of healthcare existed long before the pandemic, was exacerbated throughout, and will be still waiting for us when we come out on the other side. And despite nearly 18% of the country's GDP going to the US healthcare system, This spending doesn't translate to good health outcomes, and that's problematic. With medical debt being one of the leading causes of bankruptcy and life expectancy still declining despite this high spending, it's clear that the US healthcare system simply isn't meeting the moment. So bringing that all together, this is problematic on the individual and systems level for the following reasons. Primarily because it's so prevalent. As I said, 1 in 5 on average receive a surprise medical bill in the current system. It's also costly. Medical debt, as I mentioned, is a major source of bankruptcy in the US, and other issues such as high prescription drug costs thwart people from using them, or people are forced to ration their insulin. That leads me to my next point, that it's bad for our health. This has a chilling effect with downstream impacts. People are either avoiding or completely unable to access care, and that leads to putting off more preventative care and having more comprehensive care. Finally, it's just not a good look on an international level. So the US is a leader in healthcare spending, yet it doesn't translate to positive health outcomes as in increased life expectancy or general wellness of our country. And so at this point, you might be thinking, hasn't anybody taken action on this if this is such a big problem? I know this is true because many of you are social workers, and that's just what we do. And to answer your question, yes, but not enough. One angle that is illustrative of this is an issue that I mentioned earlier of surprise medical billing. I've been following the movement of federal legislation on this issue for nearly 2 years, and I can tell you it's been a process. Its enactment followed nearly 2 years of congressional debate over competing approaches to the problem that at times appeared to be completely deadlocked. I thought this thing was dead in the water many times. And it was less of a debate between Congress at times and rather between insurance carriers and doctors who each put a lot of lobbying behind their cause. Yet, as something of a Christmas miracle, if you will, the No Surprises Act passed in late December of 2020, marking a rare occasion of bipartisan agreement, particularly when it comes to health policy matters. The COVID-19 pandemic reiterated that there was no better timing to ensure consumer protections exist, especially when more and more people would be seeking emergency care or obtaining it out of network, out of absolute necessity. And I want to start by saying that this is great news and a net positive for patients. But frankly, I and other health policy spectators have mixed feelings about this. For one, I was a bit disgruntled because I was hoping to advocate for passage of this legislation as part of my project. But nevertheless, I took the win and busied myself with understanding what this legislation meant instead. Without getting too far into the weeds, and I'd be happy to do so afterward, the new law applies to nearly all private health plans offered by employers, as well as non-group health insurance policies offered through and outside of the marketplace. The new law also holds patients harmless and sets out to have doctors and insurers duke it out themselves, so patients can avoid the sticker shock of receiving an exorbitantly high medical bill. So here's what to know about the legislation, and this one might be a bit of a wonky doozy here, but the primary thing is that the legislation that passed utilizes baseball-style arbitration for negotiation. Under this model, the doctor pitches a number, and if insurance doesn't want to pay that, it goes to arbitration. The doctor and the insurer each list a number, and they make their case to a panel of independent judges referred to as arbiters or arbitrators. They then pick among the two numbers pitched with the idea that it makes it less likely that either side would offer some ridiculous number and skew the median cost if they were to go for the average of those two. So the biggest advantage of that is that it holds the consumer harmless and the patients don't have to be shocked by that number, but also that they can create an agreement between the doctor and the insurer moving forward to ultimately just go for a more reasonable cost. So this new legislation also suggests looking at median in-network rates rather than that so-called sticker price that's often much higher than anybody is actually willing or able to pay. And it's kind of like a car dealership where you're expected to haggle a bit. So under the law, doctors are only able to bring bills for a particular service once every 90 days, therefore disincentivizing continually high billing practices or clogging the system with appeals because they don't like that method. Instead, this incentivizes the insurer and the doctor to come up with an agreement for that service moving forward. Additionally, not seeing an out-of-network provider simply means that it's much less likely that you're going to get a higher bill. This law also reduces the predatory practices of private equity staffing groups and may lead providers to bundle services in more cost-effective ways moving forward. Finally, preliminary data from states that have arbitration suggests that this may lower premiums by 0.5% to 1%. And I know that doesn't sound like a whole lot, but these are historically very difficult to reduce. And that comes with the caveat that costs can still be high if you're within your deductible, but overall, this should help with avoiding those egregious bills. Moving on to some cons of this legislation, lack of a ban on bills generated via ground transportation, and this includes air ambulances such as helicopters. Unfortunately, these bills are a common source of surprise bills, as they're often used in emergencies where patients may need to receive specialty care or go to a facility they don't typically go to out of emergency circumstances. And oftentimes in those scenarios are unable to consent to receiving care from an out-of-network provider. Next, there's risk of consolidation of those providers who have made a business out of leveraging surprise billing. So dumping these private equity doctors from networks may lead them to band together. And there's even language in the bill advising lawmakers and otherwise to keep an eye out for it. In other words, people who are looking to make a buck are probably going to continue trying to find workarounds, and it's something we'll have to be vigilant about moving forward. Finally, the last wonky piece is the 80th percentile of bill charges. And this is that sticker price that I've been talking about. So in states that have baseball style arbitration, such as New York and New Jersey, judges reference bill charges, which reflect that higher sticker price and tend to be on the higher end of what doctors expect to be paid. As many as 2/3 of all decisions in these states end up being near those higher cost numbers. And while it's not bad that doctors are getting compensated adequately, the burden then falls on patients and will be something to keep an eye on. The federal law might copy this problem, but at this point, it's too soon to tell. And what we do know is that the law advises arbiters against looking at those bill charges and instead suggests looking at median in-network rates to be a little bit more fair cost-wise. If you're still with me, I'll take a breath here. I know it's easy to poke holes in legislation, and perhaps that's because it's underpinned by this broader issue of fragmentation. And there's so many other issues associated with this, but here's just one angle. But it's progress nonetheless. And the main takeaway I want you to have here is that this is an evolving issue and one worth paying attention to, as it may set the tone for health policy reforms moving forward. In the simplest terms, there's no denying that it's a win for healthcare consumers facing ridiculously high medical expenses, and it's a step in the right direction, but certainly no magic bullet. And there are still other ailments of fragmentation. As I mentioned, high prescription drug costs, availability of these junk plans that don't offer good comprehensive coverage or quality access to services, and consolidation of healthcare systems. As I mentioned, people will always be trying to make a buck, and it's just unfortunate that this is occurring at such a large scale and with something as vital to the entire population as healthcare. So what to anticipate then moving forward? I hate to leave you with a cliffhanger on this, but the rulemaking is coming up next month and implementation of the policy is set for January of next year. As badly as I wanted to have this all solved single-handedly by the time this presentation rolled around, I'm recognizing that there's more work to be done, and that'll include the collective effort of many. And here's what I can tell you. Despite 30 or so states having implemented surprise billing bans, these policies are relatively new and lack broad-scale understanding of their efficacy. For that reason, it's hard to infer exactly how this will play out at the federal level. I'll certainly continue to follow this issue, and if following them is of interest to you as well, I've put together a resource with some jumping off points for you to better familiarize yourself that I'll be putting in the chat. And of course, I'd love to connect with you on the side, but the main takeaway here being that things maybe aren't crystal clear, but worth paying attention to, because this really might be the catalyst for health policy reforms moving forward. Finally, even if healthcare policy isn't your shtick, I hope you can take and recontextualize the following takeaways in your own work and chosen issue areas. Incremental progress is still progress, but we have work to do. The pandemic really showcased the need for fundamental change and attention to disparity across many sectors. And while I've mainly been harping on one individual issue, I do so with the intentionality and understanding that one angle can add contrast and perspective to a broader issue, just as surprise billing does with the broader issue of fragmentation. No matter what system you're working in, I imagine many of you have your own respective areas where this applies, and this is a signal that we need to transform our services and act in ways that prioritize humanity and meet the moment. Next, attention to cost, access, and quality of care and the services we either provide or oversee are vital to understanding the performance of the systems in which we operate, and social workers especially have a role in this. In all things involving humans, collective action is absolutely necessary. As social work professionals, we need to find strength in the fact that we are such a wide-reaching profession. We are uniquely situated, and this is a testament to the utility of social work values in promoting policies and cultures that uphold dignity and worth for all, standing for diversity, equity, and inclusion in all arenas, and better resourcing every environment we find ourselves in. In closing, I want to remind you all that to make progress, we need to relinquish ideas of feasibility and dare to challenge the status quo. The pandemic has proven that when we act boldly and creatively outside of the constraints of bureaucracy or ideas of how it always has been, we can truly cure what ails. I appreciate all of you for your time and attention today, and I also want to extend my thanks to my peers, friends, and family, the Network for Social Work Management for this opportunity, and especially my mentor, Mark Lamar, for their abiding encouragement and support throughout this entire process. As I wrap up, I'll drop a few links, including my contact info and that resource in the chat. Thank you again, and enjoy the remaining presentations.
So we have a question. We have two questions that have been posed. So Haley, what I'll do is I will read these questions for you to frame your answers to. So the first question we have is, do we know which elected officials are pushing for these changes as far as the legislation is concerned?
I would have to follow up because when I was tracking at the congressional level, there were two respective committees that were kind of going back and forth, and that's why there was a bit of a stalemate there. So I'd have to look at specifically who is doing so and follow up on that one.
Thank you. And the next question is, which issue do you think is the most pressing right now?
I really feel like they all fall under this umbrella of fragmentation. And I know I didn't go into a great deal of depth on what that means because it just all feels so intertwined. Like the more I learned about surprise billing, the more I understood that this has implications for people accessing care and ultimately, receiving higher prescription drug costs. And it felt like kind of a snowball effect. So it's really hard to decide which meets the demand. And I would say that surprise billing is one of those because it actually rose to the top and passed, which kind of came as a surprise to most people who were following along. But it was part of that bigger spending package. So I'm glad to see that it was reflected in the relief packages and understood as a genuine concern and something that needed attending to.
Thank you so much.
Thank you. Were there any other questions here?
If there are any other questions, please feel free to put them in the Q&A box.
And I do believe we have your mentor, Mark Lamar, on the line as well.
Wonderful.
Yes, I'm here. And I want to say thank you, Haley, for bringing it all together as you just did. This has been a work in progress. And when we overcame our own surprise at the surprise billing, sort of the midnight passage last December, and had to reframe and stand up. You still took hold of this by the horns, absolutely, and walked it across the finish line. Working with you, I've been so pleased by not only, call it your wonkiness. No, you know this stuff really well. You're able to dive deep on it and then explain it. But you also bring the essential heart of all of this into the discussion as well. And your description of this, of our healthcare system, as if it's a board game and we have pieces that don't match and don't pertain to the rules. It really is it's a terrible problem of fragmentation. There's illogic to it everywhere, and unfortunately, the profit motive continues to be the overarching energy. But you've articulated this so well. I love the product. I love what you talked to us about today, and I can't thank you enough. It's just been a pleasure.
Thank you very much. I so appreciate your kind words and mentorship throughout this entire process and the rapport that we've been able to combine in this program. So thanks again, everybody, and really looking forward to hearing the rest of my peers' work, and happy to connect on the side too if there's any outstanding questions.
Thank you, Haley. Thank you, Haley. So as we get ready for our next fellow, I so appreciate Haley's presentation because I remember when I ruptured my Achilles and had to get medical care. I remember those surprise bills coming in the mail, and you think these things are covered by insurance. And the irony that I found was that you find out exactly what isn't covered once you have medical emergencies. So thank you, Haley, for addressing this very important issue. And thank you, Mark, for the mentorship and the support that you've provided to Haley, and the product speaks for itself. Thank you. So what we are doing now is we are in transition. Our next fellow, who I'll be introducing momentarily, is getting set up. We're doing the back end things to keep us moving along so that things continue to go along smoothly. Thank you for your patience. We're working to keep our time schedule so that people who are logging in for a specific fellow based on time constraints are able to sit in on their entire presentation. And this comes from the lessons that we've learned from years past. And just another reminder, if you have like your comments that you want to share as the presentations are being displayed and showcased, we ask that you use the chat. If you have a question, we ask that you place that in the Q&A, and you can find those on the bottom of your, the toolbar located on the bottom of your screen. So it's that time. So next up, we have Mr. Mark Liptrap. Mark, you're up.
Good morning, everyone, and welcome to my office at the Monongalia County Health Department in Morgantown, West Virginia. My name is Mark Liptrap, and I am the Monongalia County Quick Response Team social worker. As I prepared this morning for my presentation, I came into work a bit early to make sure that my slide presentation was ready to roll and that I had all my notes ready. As I began to get closer to my presentation time, I started to have a little increase in anxiety. And what I tried to do was to ground myself in some of the techniques that I have learned over the years. But one thought came to mind. I thought, if one person, as a result of my presentation, will be able to seek help, then my anxiety is worth the effort. I also had a more dim thought, and it also emerged. Someone is homeless right now due to substance misuse and mental health illness. I thought about that, and it helped to ground me in the aspect that this work is so much more important than my anxiety. So it is my pleasure today to present on giving new life to Haddon's matrix to combat epidemics. The CDC, in the Principles of Epidemiology and the Public Health Practice publication, refers to epidemics as an increase of often sudden in the number of cases of disease above what is normally expected in a population area.
And I'm sorry to interrupt you, Mark, but we can't see your screen. So if you don't mind sharing, and then we can go ahead.
My apologies.
No worries.
I did forget the share aspect of it. Alrighty. Okay, my apologies. There's the second slide. And so what the CDC said about the epidemics is it's a sudden increase in a disease than what is normally expected in the area. So when I decided on the direction of my presentation, I was focused on the opioid epidemic. That focus came because I began work as the QRT social worker at the health department. Public health was new to me and to my role as a social worker. So as I began to learn more about the projects here at the QRT, I also thought about the connection between mental health and mental health epidemic and the opiate epidemic. I think for centuries, we have dealt with both mental health epidemics and we've dealt with substance use. I think many people know the history of Coca-Cola and that the idea of Coke came about as a stimulant approach to helping others. Two stimulants, the cocoa nut, also spelled C-O-L-A, and then cocoa from the cocoa plant, had produced this marketing material, and it was touted to alleviate headaches and act as a brain and nerve tonic. Also in Central Asia, for at least 4,000 years, priests and shamans have been ingesting plants to induce a dissociative trance. This both fits into the category of opiate epidemic and mental health epidemic. My thought was, which came first? The idea that most of our concerns are so interrelated to the opiate epidemic and the mental health epidemic, it's sometimes very difficult to tease out which services are needed. And most of the time, we can do a multi-approach to try to get the services needed for both of these epidemics. Stigma has long been associated with the misuse of substances and mental illness. I'm an avid fan of Law and Order, and one evening I was watching the Talking Points episode from season 17. The defense attorney began the closing argument with 3 racial slurs. It immediately created outrage in the courtroom. This was the inspiration for my poster. Most of the time, these words elicit some very negative connotations. And still today, many of these words are used in some aspect. A simple Google search would show that if you Google search treatment facilities for opiates in West Virginia, the Addiction Center pops up. When that pops up and you go to their webpage, the very middle in bold is West Virginia drug rehabs. I had actually conferred with a longtime friend and asked his opinion of drug rehab and the word. He also confirmed that it was a stigmatizing term to him. I think that what we need to focus on is what in environment is adding to stress, anxiety, and some of the substance use, mental health issues. Societal stresses have long been a source of people trying to alleviate those stresses. So we have lack of housing, unemployment, gun violence, mass shootings, racial issues, politically toxic environment, and lack of services. Just a side note, yesterday, Congress passed a bill making Juneteenth a federal holiday. As soon as the President of the United States signs that into law, we will have a new federal holiday. It's been approximately 40 years since we have had a new federal holiday, and this can help to maybe reduce some of this racial issues that are currently present in our country. Pandemic fatigue is a real and oftentimes very problematic situation that we all have been dealing with for quite some time. Recently, we have all begun in the United States to kind of open up and try to get somewhat the sense of normalcy back into our lives. I think specifically dealing with the pandemic and how the pandemic has added to the increase in overdoses in West Virginia and also an increase in mental health in West Virginia is a concern that we need to address. There's many approaches to address this. So one thing I'd like to share with you is just some of the steps that West Virginia has taken over the past decade or so to try to alleviate some of the issues with the opiate epidemic. West Virginia has opened a variety of treatment modalities in the state. Lawsuits have been won to fund treatment and prevention. There was also the development of the West Virginia Office of Drug Control Policy to kind of have a central location to get information and data. Naloxone distribution has been a real benefit for people being able to curb the potential for death of ingesting too many substances. And one reason that I'm very proud of West Virginia is the development of the quick response teams. As you can see in this post, there are a group of professionals that actually use their professional training and techniques to be able to reach people that have experienced overdoses within 24 to 48 hours. I have to say, in my 16 years of social services work, I have never met a group of professionals that were so dedicated, committed, and tirelessly working to try to end the overdoses in West Virginia. I commend everyone that's a member of the Monongalia County Quick Response Team, as their work has inspired me to continue doing what I'm doing. And it inspired me to put a definition on my fellow presentation. One of the things I'm looking at trying to move forward and do would be to take some of the information that we have done at the QRT to the legislature. So I want to share that some of the people that are key partners in the QRT presented their poster presentation, which is on the screen, to the RX Abuse and Heroin Summit in April 2021. As you can see, these are the numbers that have proven successful with our particular QRT. The partners are kind of listed in the middle, and they are the integral parts of trying to get all of these numbers to be utilized as a method to try to reduce substance-related mortality and morbidity. And I feel, and many of the other partners of the QRT in Monongalia County feel that we are on a track to really try to put a dent in the overdoses in Monongalia County. The data on this slide is as of March 1st, 2021. So it is relatively current. I know many people probably have an idea that sometimes data lags behind by a year or so. So I think what has been instrumental in the past few months in particular is the Monongalia County Quick Response Team has really stepped up the data approach and getting a more fine-tuned ability to get the data, get it out there and get it documented. I think that this just demonstrates the ability that we can move forward and try to utilize good approaches to do this. So Dr. William Haddon Jr. back in 1970 had actually been one of the foremost entities to utilize the Haddon's matrix for vehicle crashes. This resulted ideally in the development of seat belts, and also developed the ability for us to utilize the seat belts to reduce deaths and significant injuries. As you can see by this slide, you could actually utilize the Haddon's matrix to demonstrate how you could possibly use this as a prevention measure. So the matrix looks at factors related to personal features, agent features, and environmental features before, during, and after the event. By utilizing this framework as an investigative and preventative tool to reduce overdoses, and also it could be utilized to reduce substantial mental illness or psychiatric hospitalization. So we are unable to predict the future, but we can surely mold the future utilizing everything that we have researched and learned to intervene and try to reduce serious mental illness and also overdoses and overdose deaths. We have long seen a history of people suffering with substance misuse and mental illness. Many positive approaches have proven effective. Yet, as everyone is aware, there is no one answer to eliminate these epidemics. The hope is we can continue to use these approaches and new approaches to combat the opiate epidemic. I think this is a great tool for utilizing the Haddon's matrix to investigate any precursors to potentially overdoses or significant mental illness, and maybe develop some preventative measures to avoid a long history of recovery, a long history of mental illness, and a lifelong suffering. So as I close, I'd like to share one additional thought. In the recent year or so in Morgantown specifically, there was an old hotel, and we all in the town call it the Old Ramada Inn. It has recently been revamped, and we are looking at utilizing that as a new social services hub for Monongalia County. The hope is, with many agencies and us here at the health department, are looking at using that as a one-stop shop type resource for social services. Many social workers have long remembered the talks and the discussions and the trainings and the webinars that one-stop shop would be great. I know in my 16-year career in social services, I have oftentimes heard that, but yet to see it come to life. This is the first time I have ever seen a real potential growth and a real potential opportunity for the social services hub to take hold, and people could actually go to one location, one building, and hopefully seek just about every service they would need. Now, we know the reality is trying to decide service delivery, what services are needed, can be a mammoth task. But I also think that would be a great start for someone to begin to get assistance for some of their life needs and their basic needs. And as they can move forward in getting those basic needs met, they are able to look towards a brighter future. So with that said, I'd like to thank my mentor, Gray, for all of his support and help. And also I'd like to thank everyone here at the health department and my friends and family for supporting me during this time. I'm willing to take questions, and I can answer questions as you would like.
Thank you so much, Mark. While we wait for some questions, I do believe we have Gray on the line in the event he'd like to say a few words.
Yeah, great job, Mark. This has been quite a year for Mark, and communication and constantly staying in contact has been really a strength of Mark's. And I will say, I think it's important for everyone to know Mark has jumped over barrel after barrel after barrier after barrier after barrel that's been thrown at him, not just because of the pandemic, but because of the changing landscape in his work. And he continues to rise to the occasion. And I think that that is an outstanding strength of Mark's, and it's something that I'm really proud of.
Thank you very much, Gray. I really do appreciate all of your support and help. And it has been a challenge, but I see the fact that I am able to stand up to the challenge, face it, and persevere through it. So thank you very much for that.
Absolutely. I completely agree with that.
So Mark, it does look like we have one question in the chat, or excuse me, in the Q&A function. And the question is, what do you think about using harm reduction as an approach to heroin use?
I believe that harm reduction can be utilized in a variety of illnesses, and substance misuse is one of those. I look at the ability that Haddon's matrix used back in the 70s and 80s to reduce fatalities in automobiles. That's a harm reduction tool. So I believe there are potentially untapped harm reduction tools out there to help this approach. As I said in my presentation, there is no one approach that has been successful at eliminating either one of these epidemics. I think working together with people that have experience, knowledge, commitment to try to utilize any tool at their disposal. One thing I also wanted to mention is early June, I heard on a news broadcast that the US Capitol Police had welcomed a new dog to their force for emotional support. That just demonstrates that there is the ability to utilize friends. And also, as I use my wonderful thing that's on my desk, this is Lucy, and she says, good advice, friends are the best kind of therapy. So I believe utilizing the tools and techniques that we have to reduce our stresses, our mental worries and anxieties can help us to fight some of the other stresses in our lives.
Thank you so much, Mark. Great job. And I can attest to Gray's, all of the obstacles that you had to overcome this year to get your presentation done. So certainly kudos to you and your resilience and willingness to just continue to persevere. Thank you. And your presentation kind of rings home for me. And there's this through line as we get ready for our next presenter. I think this may kind of give context a little bit to Mark's presentation as he wrapped it up. I love the word substance misuse. As you talked about the stigmas that are associated with it. And that rang personally for me because after coming home from Vietnam, my dad wrestled with substance abuse for a number of years and ripped up our family. And it wasn't up until maybe 5 years ago that he was given an official diagnosis of PTSD. So imagine 45 years after serving your country that you get a formal diagnosis, and the substance misuse, which was more than likely a coping mechanism, he didn't have the support that he needed in order to get the treatment that would have been necessary for him to, get himself cleaned up and to keep his family intact. So I have a strong appreciation for substance misuse. So thank you so much for your presentation, Mark. Thank you so much. And as we prepare and get ready for our next presenter and the next handoff, there's this through line. So we have, the fragmented system, and we have surprise billing, and we have, down in West Virginia where they're actually going to be building this facility where they can get integrative care. Integrative care can be provided. It just reminds me of my colleagues who presented last year who had talked about integrative care, and if I'm not mistaken, that was Rain. So just seeing how all of these issues are integrated and interconnected is really huge. So have a really fond appreciation for all of the fellows and the work that you've done and the work that you're doing. So what I'll do to get us queued up for our next presentation is I will give a warm handoff to my colleague and fellow from last year's cohort, Rain.
Yes, thanks so much, Dennis. And you're seeing my face and not Grace for a very important reason, but I do have the pleasure of jumping in to share a Grace Downs presentation for you all here today. She was unable to join us live, and you'll hear a glimpse into why towards the end of her presentation, so I don't want to give it all away, but it's a positive reason. But she has provided a pre-recorded version of her presentation so that she could still share her work with you all today. She does send her appreciation for everyone in attendance. So here we go with Grace Downs and what about the client's experience, giving voice to the client's experience of services. Apologies, I don't think I was sharing audio. Hold on just a second.
Hello, my name is Grace Downs. I'm a program coordinator and clinical supervisor within a care management agency in a large New York City hospital system. Care management services are meant to improve clients' experiences of medical services as well as enhance coordination of services that's happening between different medical providers. I've worked in my agency for the last 6 years, and I've been a supervisor there for the last year and a half. Even as a care manager or direct service worker, I've always noticed that we didn't have a formal feedback protocol or policy around gathering patient complaints until about a year ago. Because there was a policy that was passed by the Department of Health, we started keeping a log of all the complaints coming in, but it's just data that lives in this folder somewhere in the internet, and we don't really utilize this information to create any changes in our policies or protocols. And the more and more I thought about how we are client-centered as an organization, I've wondered how these things can really be true if we're not taking the information and the feedback and then creating change within our setting with it. So this is kind of where how I decided my topic, and throughout my presentation, my goal is to just paint a very broad picture of what this topic is and what it can look like in organizations, and as just some ideas on how this can be improved in our social work settings. So when I started off, I had a very ambitious goal of having a patient feedback initiative implemented at my job. I had talked to my leadership about it. They were pretty on board, even acknowledging that this was something they thought about being important in the past, but because of other priorities, it's never really taken off. So they were pretty excited about having someone who wanted to take this initiative. But as you'll learn, I did encounter many barriers to having it come to fruition. I will talk about that and the barriers that do come up sometimes when these types of initiatives are initiated in organization. When I talked to my leadership about wanting to do this project, I was very, very clear that it was important to me not to just do surveys, get data, talk to patients, and then just do nothing with this information. If I was going to take this on, I really wanted to be able to use this information gathered to use it to improve the client's experience of our services, and to have it increase patients' voices and participation in program development, right? This is not an uncommon issue that comes up. A lot of the times you have organizations do surveys, but then they never really analyze the data, they never utilize it for anything, and then it just makes clients feel like, why did you do that, right? So I didn't want to recreate this pattern. I wanted to make sure that there was commitment to utilize this information and implement some change with it. And the reason why this I think is important to be clear on that being a goal is that I do think that there's a belief in organizations that client-centered care really is just about the direct service that is being provided by the care managers, the social workers, and there's often a gap between what the program policies and workflows are and what is actually happening at the direct service. So if we can make sure that client-centered care is always at the core of at every level of the work that's happening in our organizations, this will ensure that client experiences of our services really are focused on what their needs are and what they think is important. So I want to talk about a little bit about why this is important to me, and I think it should be an area that there's an increased focus on in organization. And the first one is just our social work values, right? We're often working with people who are not given opportunities to have their voices heard. So as professionals, we really should be creating avenues for this to happen more and more, and for these things to be amplified, right? So it's not enough for the patient to just be able to talk to their care manager, but for their needs to be addressed in a more macro level and to be reflected within different levels of organizations. So I think it's an opportunity right now for social workers who work in these various settings that are trying to work on improving equity, improving anti-racist culture, improving access to care, to bring this as part of their focus in these initiatives. Like, okay, how are we really trying to talk to our clients? How are we understanding their experiences of our services, and how can we better ensure that we're aligning our protocols, our processes, and our access to reflect what they are saying is an important piece or an important area for them. Another reason I think we should be paying more attention to getting feedback is that as funding streams change, as the economic picture shifts, we do experience, or we have been experiencing an increased focus on outcomes. And a lot of these outcomes are about compliance numbers and measurements that don't often paint the full picture of social work interventions that are being provided. So gathering feedback from clients can allow us to have data that isn't being reflected in these measurements, and provide greater context to the value of the work that we're doing. And then lastly, I really believe that if we better align our processes, our policies, our initiatives to hear from patients, we're going to get greater buy-in from them, right? Because the work we're doing is going to be really reflective and meeting the needs of the communities that we're serving. So as I began to look into this topic more in depth, I thought it would be important to understand what, gathering client feedback looks like right now in social services. And what I found is that there isn't a lot of research out there on this, right? There's a very small amount of research in this area, and there's a lot of barriers for why social work settings are not able to, implement these processes. And the articles that I did find in journals talking about gathering client feedback of services were really focused on social work students and why it was an important part of this student evaluation process, which I thought was really interesting because somehow it's really important when we're students, but once we're out in the field and practicing, it becomes something that is just not generally happening. And again, it just makes me think about what our values are and how feedback should be an ongoing process that happens throughout our whole career. So I thought that was an interesting finding. But what I did find is that there are just a lot of barriers that I experience and barriers that come up every day in social work settings or settings that employ social workers, which usually are really administratively burdened, have a lot of regulations, and create this challenge to having it implemented. So now I want to talk a little bit about some of the barriers that I encountered in trying to have this initiative implemented in my setting. And it's also barriers that commonly come up in social work settings when they're trying to gather feedback from clients and utilize the information. So one barrier, which is not reflected in the research, but is probably not surprising to any of you, is the COVID-19 pandemic. Being in a healthcare setting, it brought on a lot of stress, a lot of work, a lot of reprioritizing. So, as the situation was ongoing, it really meant that we had to shift our focus a lot of times throughout the year, even recently still, as early as like February, not knowing where things are going. And then, the vaccine rollout really expanded in New York City and it changed a lot of things, but really just being kind of in a crisis mode for an extended period of time. A second barrier that came up for me, which I know is something that's not unique to my setting, is our funding was significantly reduced in the end of the year, and that meant we had to restructure and downsize. So our focus from leadership level, even for me as a supervisor, really came to how do we reduce our staffing without disrupting services, and how do we do that in a way that clients, can still be getting the needs that they have met. So really just the shift in priorities really had to happen rapidly. We were in a deadline, so it made it really challenging in this moment to do the actual surveys, even though the groundwork had been done. A third aspect, which I think comes up a lot in a lot of different settings. I know my setting is a Department of Health program, so we are heavily regulated and have a lot of administrative work that we have to do. So when thinking about adding work or tasks to staff, whether it be the care managers or supervisors, there's often a need to really make sure that we are balancing the costs and benefits of it. And as an organization, we're evaluated on compliance measures, right? Assessment completion, care plan completions. And, sometimes staff are doing 3 to 5 assessments a month, which are 40 pages long, on top of the ongoing work. So it really is hard to think about how to add an additional workload to staff, and especially when there's not an incentive for that, right? So if we were being evaluated to some degree on what the clients' experiences of our services are, I could see as an organization being able to really make it a focus. But when that's not the case, it was, as much as we can acknowledge is important, it's really hard to make it a priority over these other things that are being measured. And then lastly, which I think does come up in social work a lot, is just this skepticism that we can really capture the work that we're doing through surveys. I remember this was a conversation in social work school and research class, for example, that like, quantitative surveys don't really capture the work. There's so much uniqueness to it, but then qualitative takes so much time, right? So it's trying to balance out the cost benefits and the value in gathering this information. And if you're not actually able to do anything with that information, what's the point? But I'm going to talk a little bit about what's happening in healthcare settings, for example, that are using qualitative data, narrative, feedback to improve their patient experience and improve services throughout these huge hospital systems, which I think are just valuable to look at to see how we can borrow some of these concepts within our own social work settings. So as it became clear to me that I was not going to be able to do the pilot, I still wanted to think about what is a good framework to think about client experience for us as social workers. And we don't have such a framework as of yet. I do think it would be important to develop one as this work is being done. But I did come across this framework, which is used in healthcare. And the reason why I was attracted to it is that, one, it's a framework that came out of the patient advocacy work that's done. It was, patients, families, advocacy groups coming together to really advocate for the patient experience to be a part of how healthcare settings are evaluated. And eventually they actually were successful in having it be a part of how their rates are determined for different healthcare settings. Now, I know there's pros and cons of that, but I think just the value of the work they did being successful and having it really impact the way organizations have to do the work that they're doing, I thought was really a valuable takeaway. And then when I looked at this framework, which I can't go through in depth, but I look at all the components that are important, especially when we're talking about culture, leadership, staff and provider engagement, patient and family, community engagement, and policy. These are all things that I think really have to be in alignment and working together to enhance the experiences of the clients that we're serving. So I think there's value in looking at this and then thinking about what can we borrow, what can we really, look at more closely to be reflective of the work that we're doing as social workers. So this is kind of a brief picture of what I ended up doing as it became clear that, again, I wasn't going to be able to do the feedback part with patients, but instead I started just talking to social workers that I know that work in different settings, not in healthcare alone. And the takeaway from my conversations with all these people, which were only 8, so I know this is not a large reflection of the field, but it gave me a lot of optimism, is that social workers do want to know what their clients are experiencing in their work, and that they think that there's value in having it be implemented into the work processes that they're doing, and that they do have a strong desire to have their agencies be more client-centered when we're talking about processes and protocols and policies. And so, that gave me a lot of hope and motivation to continue this work moving forward. And then another thing that I had the opportunity to do as part of our anti-racist initiatives at my organization is join the patient engagement committee. Which when I joined, a lot of the conversations were talking about partnering with CBOs and different community organizations. And I remember just saying like, why don't we just talk to the patients? And everybody was like, oh my God, yes, that's what we should do, right? So even me finding an opportunity to make sure that we're bringing things back to let's talk to the people that we're serving, I think was a success for me, even though I wasn't super successful in my larger goals that I talked about earlier. So, briefly, I just want to talk about what I think are some ways to continue working on this project, and I plan to continue working on this. In my organization, I already had a lot of conversations about doing the surveys when the time is right. And to me, it will look like doing telephone surveys or text surveys or using other technologies. I think we're at a time where we have access to technologies that will make this a little bit easier. And I want to implement that and give it a try. Another idea which I have introduced to my leadership and colleagues is maybe creating a client advisory board for our agency. It's still unclear what this can look like, again, being a HIPAA compliant healthcare setting and being regulated by the Department of Health. But I do think that there's a lot of value in doing the work that needs to happen for clients to be part of our organizational meetings and conversations, and having client representation in our meetings, as well as our budgetary decision making. I think ultimately, when we're thinking about budgets, the way we spend the money is really a reflection of the priorities of the organization. So I think having some sort of representation within our program development, our budgetary processes, will really enhance the opportunities for patients' voices to be heard and for us to stay on top of those things as priorities. And so just like my final thoughts are that, I hope everyone can walk away with just, thinking about what does this look like in my setting, right? Do we talk to our patients? Do we really have feedback on what they think is important? Do we really understand what their experiences are when they're walking through our door? And, if you don't feel like you have a good sense of that's happening, maybe just asking a question to your leadership. Get an understanding of what they think, how they think patients' experiences are being reflected in the work. And hopefully there can be a larger conversation after that. And then lastly, I just want to thank the network, especially Dennis and Rain, for their support throughout this last year, my mentor, Dr. Dennis Cow, and then just various colleagues that I've met and who have supported me throughout the last year or so, 9 to 10 months, especially as I'm about to have a baby in a week. It was really hard to get through this last stretch. So without their support, I don't think I would have done it. Thank you. And lastly, these are just all of my references that I use to support a lot of the areas that I covered.
Thank you, Grace. Grace, thank you so much. And it was an absolute pleasure to work with Grace. It was an absolute joy and a pleasure to make sure that we, as an agency, as a social work agency, were able to support a fellow social worker in her endeavor. And Grace truly barreled through to make sure that, she put herself in a position ideally to make sure that her presentation was done. And it was just tremendous to be able to support her. And I'm certain that Rain co-signs on that. So we are definitely really satisfied and grateful for her efforts and the resilience and the perseverance that it took to get through to the finish line and to do that, knowing that she was going to be giving birth. So thank you. And if you have any comments, you can please put those in the chat. Let's give Grace thumbs up, clappy hands, LOLs, send her some love, so that, when she gets the opportunity to watch her video, that she'll see the love that was sent out to her. So as we prepare for our next fellow, We are, again, I just want to remind us that we're staying within the time constraints that we have set up so that people who want to log in to watch the fellow, whether it's a family member, colleagues, friends who may want to watch their presentations, that they are able to log in at the time that they know that they're going to present and not log in. And, you know, the person that they wanted to see present is halfway through the presentation. So we definitely want to we're trying to just keep pace. So bear with us as we keep our pace. And let's keep those comments and things coming in for Grace. And again, if you have any questions, would you put those in the Q&A? If you have comments that you want to send directly to a fellow or a colleague or someone that is in attendance, would you please put those in the chat? Greatly appreciate it. It'll help us to keep track of questions and comments. So we seriously appreciate that so much. And just as a quick note, this upcoming fellow, this will be the final presentation of this segment, after which we're going to take a 15-minute break. So I just wanted to kind of prep everyone. We'll still be here, but I just wanted to give you a heads up that this will be the concluding presentation of this segment, and then we'll be moving on to our break, and then we'll move on to our next segment. So thank you kindly for your patience as we keep our pace. And we're just coming in at a little over a minute here before we hear from our next fellow. All right, our next fellow coming up, the next face that you'll see and the next voice that you hear will be that of Elsie Silva. Elsie, you're up.
Okay, hi, can everyone hear me? Okay, so my name's Elsie Silva. I'm a licensed clinical social worker, and I want to thank all of you for being here today with me. I'm just gonna want to set this up really quickly. Okay, so I just first want to start off with this is the title of my presentation is actually called Redefining the Standard of Care at Residential Care Facilities for the Elderly, otherwise known as RCFEs, and how preventative measures can help the quality of life for residents and caregivers. Before I start, I want to state that this is a systematic literature review. So I'm going to be using various journal articles, written papers, data analyses that all provided the insight and information needed to properly discuss this issue. I'm also going to be talking about, or I'm also going to be using some personal insight given my background working with this population. So what population and what is happening? Well, according to the California State Plan on Aging, California is home to more than 7 million people age 60 or older. And by 2060, that population is expected to reach 14.7 million, which is an increase of 88% from 2016. The lines that you see here actually break those projections down between age groups. And this project will be predominantly focused on the 85 and older population. As you can see in the light blue, California's 85 and older population is expected to grow from about 600,000 in 2010 to over 2.25 million in 2050.
I'm so sorry to interrupt, Elsie. I don't think we're seeing what you're intending to show. We're still stuck on the first slide here.
Oh no.
So if you want to reset, that's totally fine.
It should be, hold on. Can you see it?
There you go.
Oh, sorry about that. Okay, so the light blue, as you can see, shows the projections of the 85 plus age group. Thank you for letting me know. Okay, so the 85 and older population in the entire United States is projected to more than double from 6.5 million to 14.4 million in 2040, which is a 123% increase. And that's important because those 85 and older have a significantly higher rate of severe chronic health conditions and functional limitations that result in the need for more health and supportive services. So as these numbers increase, there's going to be a higher demand for the type of quality care found in California's assisted living facilities, such as RCFEs. So, who can afford RCFE level of care though? The average monthly cost is about $3,500 a month, but it could be as high as $5,000 to $6,000, depending on accommodations. So a crucial component to discuss are the poverty rates among older adults, as that's going to play a key role in who will have the capacity to access the services necessary to age with dignity at home or move into facilities that can provide that level of care.
Elsie, I apologize again. We may want to just have you stop sharing and try to reshare again. We're still not seeing it advancing, I don't think. So no worries. Yep. Just take a breath and not a problem, because we have a little bit of time and we can always cut this part out for your recording.
Okay. Can you see it? The poverty rates?
Yes.
I wonder why it's doing that. Okay. Is it actually following now my slides?
Yes.
Okay. So I was talking about who can afford our CFE level of care, the average monthly cost. I got to the poverty rates. So you guys can see the poverty rates now, right?
Correct.
Okay. So sorry about that again. So nearly 1 in 10 older adults live below the poverty level, and older women had a higher poverty rate than older men in 2018. Now that's significant because older women outnumber older men, and the proportion of older adults who are female increases with age. In 2012, for example, 57% of all adults age 65 plus were women, but in the 85 plus group, 2/3 of them were women. And when we break that down into race and ethnicity, we see that poverty rates continue to disproportionately affect older adults from minority backgrounds. We can see that the African American and Hispanic population have almost double or more than double the rates of their white counterparts. And the Asian population also has a significantly higher rate. The highest poverty rates were actually experienced among older Hispanic women who lived alone. So a crucial component to look at is going to be the living arrangements of older adults. In my analysis, I found that the proportion of older adults who live alone increases with advanced age for both men and women. With women over 65, 34% lived alone, and with men, 21% lived alone. But in the 75 age group among women, that increased to 44%. And that's important to note because, as mentioned earlier, physical limitations increases with age. Therefore, the need for caregiving increases with age. So the Department of Healthcare is actually aware of this growing trend, and they've addressed these challenges through the new CalAIM proposal, which stands for California Advancing and Innovating Medi-Cal. CalAIM as a whole addresses many of the complex challenges facing California's most vulnerable residents. And I'm not gonna bore you with the details of the proposal, given that it's over 200 pages long, but I do want us to focus on a very small segment of that proposal called In Lieu of Services. So in lieu of services is something that the Department of Healthcare Services is proposing, which are flexible wraparound services that a Medi-Cal managed care plan can use into their healthcare strategy. And these services are supposed to be a substitute to other covered services. So it's supposed to substitute for hospitalization or skilled nursing facility admissions. So these are for members of high levels of risk. And there's 14 distinct in lieu of services, which we can see to the left-hand side. But the only one that I want us to talk about is the one in the middle, which is nursing facility transition diversion to RCFEs. So what does that mean? It's basically saying that high levels of risk individuals that do not need nursing level of care should be transitioned to RCFEs in order to prevent institutionalization, provide a more home-like environment, and improve the quality of care of its residents. So how is this going to be done? Well, there's multiple managed care plans throughout the state of California, ranging from Molina to Anthem to Blue Cross. And these managed care plans are going to have to contract with RCFEs in order to have the capacity and the knowledge to provide the appropriate level of care for these high-risk residents. So then what's the problem? Why am I talking about this? Well, we have to first look at how RCFEs are being regulated compared to skilled nursing facilities. Skilled nursing facilities are medical facilities. They're licensed, they're regulated, they're inspected, they're certified by a number of public and private agencies at the state and the federal level. And these agencies have separate yet sometimes overlapping jurisdictions that ensure that healthcare facilities comply with state laws and regulations. RCFEs, on the other hand, are non-medical facilities, and they're only regulated by one entity, the California Department of Social Services. The California Department of Social Services has the Community Care Licensing Division, which is in charge of licensing and regulating RCFEs. Now, in the 1970s and 80s, this Community Care Licensing Division, otherwise known as CCL, inspected RCFEs twice a year. But in the 1990s, that was cut down to once a year. And in 2004, those inspections were slashed to once every 5 years. From my analysis, there is data that suggests that CCL has been unable to meet even the minimal 5-year inspection mandate. And this is a quote from the California Advocates for Nursing Home Reform stating, once a model for other states, California's inspection system for RCFEs is now one of the weakest in the nation. CCL is also in charge of investigating cases of abuse and neglect. And outside of making a formal complaint with CCL, residents are encouraged to contact their local ombudsman office. Ombudsman services are supposed to help resolve problems related to health, safety, welfare, and the rights of individuals. And if we look at the fiscal year data for last year, 2019 to 2020, we can see that there's 35 local ombudsman programs throughout the state of California with 205 paid staff and 508 volunteers that are supposed to oversee over 308,000 long-term care beds, which includes skilled nursing facilities and residential care facilities. Now, a report from the California Senate Office of Oversight and Outcomes stated that California's ombudsman program depends on networks of volunteers overseen by paid staff. Some local programs don't allow volunteers to conduct abuse and neglect investigations, stating that they're too complex, too time-consuming, and they're beyond the scope of what most volunteers can expect. And you would think that's great, right? However, when you look at the number of complaints per category, you see that in the same fiscal year, there were over 10,000 complaints of abuse, neglect, and exploitation. There were over 6,000 complaints related to resident care and almost 2,000 complaints related to quality of life. So from the same report I used earlier, it actually stated that some local programs say that the demands are so great and the paid staff stretched so thin that they must depend on volunteers. And a 2005 study actually found that half of California's local programs allow volunteers to play a role in abuse and neglect investigations. So we can just imagine how these are being dealt with if volunteers are not as properly trained as paid staff. So another crucial component to look at is how administrators and caregivers are being trained. According to my analysis, RCFE administrators are not required to have a college degree or professional license. And that's regardless of whether the RCFE is licensed for 6 beds or 100 plus beds. And that's regardless of the health conditions of the residents. The employment requirements for the direct care staff, which are the caregivers, is very minimal. They have to be 18 years of age and pass their criminal clearance, and they have to have 40 hours of training during the first 4 weeks of employment. If we compare that to a manicurist in California, they have to have a high school diploma GED, 400 hours of training, and pass a state exam. So the people that are doing our nails are getting trained more than the people caring for our elders. Training is crucial. The lack of adequate staffing standards puts residents' health and safety at risk. According to a 2017 report from the Coalition for a Fair and Equitable Caregiving Industry, it stated that abuse, neglect, and overall poor quality of care and life for residents in RCFEs are results of structural systemic problems. Shortage of staff combined with long hours results in worker fatigue, which increases the risk for errors. And caregivers have not been properly trained and supervised to deal with acute levels of care needed by residents. One of those acute levels of care includes fall risk. With an estimated incidence of 1.6 falls per person per year, falls are gaining increased attention in residential care facilities. And although most of the falls result in minor injuries, 63.5% of annual accidental deaths in the US, of those older than 75, are caused by falls. And besides the physical complications, falls lead to psychological consequences such as fear of falling, depression, and social isolation. So let's look at social isolation and prevalence of loneliness. In a systematic review and meta-analysis measuring the prevalence of loneliness in care homes, findings indicated that around 61% of older people living in care homes may be moderately lonely, and around 35% may be severely lonely. So then we have to look at the health effects of social isolation and loneliness. Research has linked social isolation and loneliness to higher risk for a variety of physical and mental conditions, including heart disease, weakened immune system, depression, Alzheimer's disease, and even death. Depression is actually among the top 10 most costly diseases in the US compared to physical illnesses. And up to 25% of costs for care of medical illnesses may be attributed to depression. This is clearly associated with longer hospital stays and higher costs. Depression is also the leading cause of psychiatric hospitalization in older adults, and it's associated with increased medical burden, health service utilization, longer hospital stays, disability, and more functional impairment than most medical disorders. Due to social isolation imposed by chronic illness and functional limitations, homebound older adults are actually more vulnerable to depression than their mobility unimpaired peers. In a research study from the University of Texas at Austin, depressive symptoms were compared between homebound older adults and ambulatory older adults that were enrolled in senior centers. The findings actually showed that as many as 42% of the homebound group, compared to 13% of senior center participants, scored 5 or higher on the geriatric depression scale, which you can see to your right-hand side. 5 points or higher is actually suggestive of depression. So that's important to note because homebound elders often suffer from a combination of physical and mental health disorders. And in a study that looked at home health patients, those with depression had a greater likelihood of adverse falls and being hospitalized compared to those without depression. So we can see that all these components are connected. So the question is, what steps can managed care plans take as they start contracting with these RCFEs? Well, they have to learn from the work already done under California's Whole Person Care Pilots. I happen to work for one of those care pilots up in San Mateo called the Community Care Settings Pilot. They've been successful at serving many of its most vulnerable members, and they have contracted with RCFEs throughout San Mateo County. When I worked there, I was actually in charge of marketing our program and contracting with new facilities. And working there also allowed me to see the challenges that a health plan can have with working with such a high-risk population. From my work at CCSP, the Community Care Settings Pilot, and the research that I've conducted throughout this fellowship, I've identified 4 steps that must happen before managed care plans incorporate this in lieu of service. These steps must be mandated. Step number 1, managed care plans need to conduct a thorough investigation of the RCFE before contracting with them. That means looking at the citations, the inspections, and the resident satisfaction. Remember what I noted earlier, the inspection system from the Community Care Licensing Division is minimal. With inspections being done once every 5 years, each health plan will need to conduct their own inspection before contracting with the RCFE, and in-person inspections need to be conducted. Step number 2, managed care plans need to collaborate with ombudsman services. Keep in mind what I noted earlier. Each ombudsman program is staffed differently, and some rely on volunteers to assist with complaint investigations. If managed care plans act preventatively and establish routine meetings with their local ombudsman program, that collaboration will not only benefit each other, but also those that they serve. The Community Care Settings program actually meets with ombudsman services on a quarterly basis to discuss those type of issues. Step number 3, managed care plans need to establish an additional training protocol for RCFE staff. The quality of care and life for residents and RCFEs cannot be improved without incorporating an effective strategy to improve the working conditions of the caregivers. And there is convincing evidence that training paid caregivers in communication and person-centered care skills is effective for symptom control. Managed care plans can contract out to agencies that can provide that training or build the training from within. And step number 4, managed care plans need to prioritize mental health, especially those that are homebound. Each county differs in regards to the type of mental health support that it offers. Therefore, each managed care plan needs to ensure that in-home professional mental health services are available. I know that with the pandemic, in-home visits were not possible, but many counties actually switched to telehealth or phone call support, and that should continue to remain available. In conclusion, as California rolls out the new CalAIM proposal and managed care plans throughout the state incorporate this in lieu of service, California can again become a model for other states on how to ensure proper infrastructure within residential care facilities for the elderly. And I just want to make one last note. If more medically complex and at-risk residents continue to be admitted to RCFEs, the state of California and the country as a whole will need to act preventatively to ensure our most vulnerable older adults are properly cared for. Within the state of California, community care licensing inspections must be increased to once a year at a minimum. RCFEs need more regulatory bodies from the state and the federal level to monitor compliance, and staffing ratios need to be mandated to meet the needs of the residents, which should be based on acuity of residents. Each of these can take me like 15 more minutes to talk about, and I'm not going to go there today. I just want to say that we have a lot of work to do, but unless someone like you cares a whole awful lot, nothing is going to get better. It's not. Thank you. I'm going to stop sharing. Hopefully all of you can see. I'm going to check my Q&A.
Yes, thank you so much, Elsie. As we wait for some questions to come in, I do believe we have Dr. Schmidt on the line. I unmuted you in case you have any remarks you'd like to share. And she may also be fumbling through some technical challenges.
This can be confusing. It's okay.
Okay, well, in the meantime, please do. Oh, it looks like we do have a question. I'll pass it over to you, Elsie.
Did research show why older females were disproportionately affected? It's just because at the end of the day, females actually, we actually last longer. I know that there's a better term for that, but we actually just live longer, honestly. And that's why we're disproportionately affected. And at the end of the day, as you see the age group kind of go throughout, we can see that females are the ones that are taking most of that bulk in the 85 plus age group. Then the next question, Medicare population folks who do not qualify for Medi-Cal may still need access to these services. Yeah, that's huge. So that's a big thing. And that's why my last slide was talking about those like additional considerations, because I'm only talking about people that qualify for Medi-Cal. Haley's question is, what are your thoughts on the Medicare population, the folks that don't qualify for Medi-Cal? And that's a huge issue that I think that as a state, as a country, we really need to talk about, because there's people in the middle class that still do not have the actual services necessary to be able to get RCFE level of care. And they don't qualify for Medi-Cal because they're not in the poverty level. And that's been an issue that I have seen throughout my career. It's something that Medi-Cal, you know, for those that don't qualify, there are ways to try and enroll yourself into Medi-Cal. There are different ways that managed care plans can help to kind of see if there's something that you can write off or if there's things that you can do to qualify for it. But unless you qualify, yeah, these services would not be possible. So that's something that we really need to discuss as older adults age as a whole. Not everyone is going to be under Medi-Cal. I'm only talking about a very specific number of people. And those that are not actually receiving Medi-Cal services are still going to need our CFE level of care, and we're still going to need to really address those issues.
And Elsie, it does look like Dr. Schmidt is having just some mic issues, but she wanted to thank you for your excellent work and am here for celebrating, or she's here for celebrating future milestones.
Thank you.
Thank you so much, Elsie. I know the work that went into this and the things that were going on behind the curtain as you were pushing through and plowing through to get this done. So certainly appreciate, everything that you put into this.
Thank you.
Phenomenal presentation, just really, really phenomenal, as everyone has been. And there's always just this through line. So thank you so much. Thank you so much for job well done. As we move into our break, we're going to have a short break, which will bring us back at 10 o'clock Pacific time. I'm not going to try to do the other time zones because I, botched those up. But if you're here, you can stretch your legs, grab a quick coffee or tea or something. We have our next group of presentations that'll begin promptly at 10 a.m. Pacific Standard Time. So we'll be back here in roughly about 18 minutes. Thank you.
Good morning or good afternoon, depending on where you are joining in from this in this second session, excuse me, and welcome to our new attendees and welcome back for those who have been tuned in since earlier today. As a reminder, I'm Rain Arndt-Couch, co-administrator of the Policy Fellows Program, and all of us here at the network are pleased to host 2 days of webinars highlighting the work of our truly phenomenal group of 2020 and 21 Policy Fellows. We're so glad that you could join us today. I will now pass things off to my co-administrator for the Policy Fellows Program, Mr. Dennis Boyd, to kick off our second session.
Welcome back, everyone. And for those of you who are joining us, welcome. Just a few things to keep us moving along so that we have a smooth transition. Number one is we have a cadence that we're working to keep so that the fellows who are presenting, some of them have colleagues, friends, family, loved ones who want to log in and watch their presentation. And for that reason, we're going to work to keep a specific schedule so that they don't log in and they find that their loved one is halfway through their presentation. So we're going to keep a strict schedule. Next is, if you have questions, please use the Q&A that you can find located on the bottom of your toolbar, and use the chat if you just want to place comments to the fellows and something you want to share broadly with the attendees. So this morning, what we had our fellows who spoke on healthcare, and they had the opportunity to showcase their policy efforts in their respective areas of interest. And now as we prepare to move on, we're going to be moving into data and technology. And then after that, you'll see fellows who are going to showcase their work in the area of housing. So sit back, relax, get yourself queued up and ready to go. So we have our next fellow who is queuing himself up. He has put in an enormous amount of work, and he has really done the grunt work and worked through some challenges over the course of the fellowship to get to this place. And I'm really excited to see what he's going to do. So without further ado, the next voice that you'll hear and the next face that you'll see will be that of Ian Williams.
Hey everybody, I'm just getting queued up here. And video is on. Can you see me? My webcam was acting a little funny earlier.
We don't see you.
Okay, plan B then. Sometimes that happens. How about now? Oh, never mind.
There you are.
All right, lower resolution, but you get what you get. Okay, everybody. So my name is Ian Williams. I'm really excited to be here. I'm a licensed social worker in New York City, and in my day job, I work as a counselor with the New York City Employee Assistance Program, and I'm also an incoming doctoral student in the social welfare program at the City University of New York's Graduate Center. Before I begin and really launch into this, I just want to thank everybody who's helped me along this process and get to this point. And especially I want to thank the Network for Social Work Management and all the staff there. My employer, the New York City Office of Labor Relations, my mentor, Dr. Ron Manderschud, my fellowship group 2 members, and my peer buddy in the cohort, Katie Gascoine. She's presenting later today, so I hope you stick around. And I also want to thank my partner for her patient late night editing and helping me get through a lot of roadblocks in terms of thinking. So I'm going to move fast because I have a lot to cover and I want to stay on time. So I hope you can keep up. Okay, so the views presented here, first of all, they represent my own and not those of my employer. The project started really to try to understand what the long-term effects of the temporary changes in behavioral health care during the pandemic, the COVID-19 pandemic might be, and particularly how telehealth was adopted pretty much across the board. So I approach it both as a clinical practitioner who was doing behavioral health services in the time, and also as somebody who's really enthusiastic, but also skeptical about technology. And I've thought a lot about social work's relationship to technology. So I use the term telehealth broadly to describe any kind of healthcare that's provided through remote means, video, audio, or other things. And sometimes that can also mean virtual care. Overall, I want to argue that telehealth's expansion is a good thing, but it's also really complex and it creates new dynamics in the behavioral healthcare field. And so to understand telehealth and where it's going, we have to understand not only technology, but the technology industry and its growing influence on healthcare. So my project is really focused on the US because of where we are and the scope of that. So I'm going to give a little background about behavioral health beforehand. Historically, the US was really slow to develop anything that could be called the national behavioral health policy. And so it was often a state and local issue, and a lot of the rules, regulations, laws, and practice systems followed that. In the mid-20th through the early 20th centuries, there were policy reforms that gradually started to integrate behavioral and somatic health into a holistic framework. And that also created a population level approach to behavioral health that really started to set in motion with the Mental Health Parity and Addiction Act and the Affordable Care Act. A nagging concern for behavioral health has been that managing an increased demand for services as they become more accessible and as they become more acceptable, but also realizing that the costs keep going up and providing services becomes increasingly complex. In 2019, behavioral health was the leading element in healthcare spending throughout the US. And insurance denial of payments for services was commonplace, as was many behavioral health providers only providing services out of network. Behavioral health has long had a labor shortage with a growing demand that was met by a shrinking supply. And at best, the workforce was about 50% of what could be meeting the national need. And even so, where people receive services varied significantly, and so did the quality. For many people, particularly poor Black and Brown persons, carceral institutions such as jails and prisons served as the main place they might receive behavioral health services, and law enforcement and police are often used as first responders for people who are in mental health crises. So lacking a comprehensive national strategy to meet the labor shortage, we've never been able to overcome it, and we have this patchwork system. Another big problem that really sets to where we are now is the limited use of technology in behavioral health before the pandemic. There's been niche applications, a lot of research projects, and the Affordable Care Act really set the ball rolling for electronic record systems. But a lot of the gains in innovative technologies in other areas of society were kind of walled off from behavioral health. A lot of it understandable because of the very strong priorities about risk management and patient privacy and all the regulations that come with that. So in March 2020, when the COVID-19 outbreak was declared a pandemic by the World Health Organization and lockdowns began to spread around the world, telehealth use skyrocketed. I was looking at studies, and in the US, in private health insurance claims, in March 2020, it was a 4,000% increase compared to March 2019 for telehealth across the board. And dominant among the reimbursements were those for claims of behavioral health. That continued to skyrocket in terms of overall behavioral health. In January 2021, a 60-minute psychotherapy session was the most billed reimbursement code for telehealth. So I just want to say that again, 4,000% increase in telehealth in March 2020 for private insurance, most of that behavioral health, and 60-minute psychotherapy session, the top private CPT code for telehealth in January 2021. So why is that? I mean, we lived through a pandemic, so that's a major social catastrophe. People are still dying, and almost 600,000 people have died from the pandemic in the US alone. Everybody's lives were upended. Death became commonplace in a way that we as humans have not seen in a while. Although lockdowns existed and were inconsistently enforced, they still interrupted life as we knew it. And we also lived through major social and political turmoil during the pandemic. We had widespread protests against police brutality in the wake of George Floyd's murder by police, and also militaristic police and state responses to that. And we also lived through an attempted coup of the federal government in January 2021. So all of that creates uncertainty, instability, and strong negative emotions. So pandemic-induced policy changes really made it easier for people to access services using telehealth, and they prioritized that in the interest of safety. So they made it easier for people to use technology and work across state lines. It also made it more affordable through things like waiving copays and cost sharing. This also led to multiple innovations in practice with technology. And overall, it really accelerated a trend of digitalization in behavioral health and really moved entire workplaces, many of them that still had paper charts and file cabinets, into the digital age. That also led to the growth of membership surges in organizations like BetterHelp, Talkspace, or virtual group practices like Headspace or Alma that sold directly to consumers. So there are some pretty serious inequities with the telehealth revolution. I overall think it was a good thing, but there's a lot of shortcomings. You know, the digital divide is a big part of how the infrastructure is set up. 23% of Americans lack home broadband access, and 15% of Americans only get internet through smartphones. 7% of Americans don't use the internet, and 25% of those are 65 or older. So current regulation changes making it easier to use telehealth depend on pandemic emergency authorizations, and the costs of maintaining sophisticated new IT are not fixed or budgeted for. And cybersecurity and privacy and data use concerns are still very much unresolved. So what made it happen, right? We couldn't have had all this widespread diffusion and proliferation without all of this technology already existing and an industry, behind that, right? Developing and maintaining things. And it's easy to just kind of take that for granted and ignore it. But I think we lose out on a lot. And I think we really need to understand both technology and the industry that produces it. So technology, I'm really talking about computer tech, and that's relatively new. If you think about the first digital computer was created in 1946. But it's a big business. There's a phrase, the G Mafia, that the author Amy Webb refers to, talking about Google, Microsoft, Apple, Facebook, Intel, and Amazon. They're kind of the titans of the US tech industry. They're also massive transnational corporations, and a lot of them are effectively monopolies in what they do. So many of the world's super rich now made their money in tech, and they have a strong influence in policy. They often see technology as solutions to failures in public policy. And a lot of the times they're also very resistant to things like progressive taxation that might finance a lot of the social services that aren't able to operate at the budgets they currently have. A real dominant ideology in tech is this concept of disruptive innovation, that introducing a new technology into an environment or a situation, that it changes things, it upsets them, and it's a form of progress that is good. And somebody wins, usually making big bucks. So big tech is also overwhelmingly a white, male, and highly educated and elite institution industry. And there's strong talent pipelines, and any attempt to disrupt that or change that has really failed. So this lack of diversity leaves some serious blind spots in terms of the world of both the users and consumers of technology, of who they're marketing and targeting. But also it raises the question of like, for whom is new technology designed? Or who is it represented in tech's visions of the future? And what are the unintended consequences of this push for disruptive innovation? And as social workers, I think we really need to think about that. So AI and artificial intelligence is one of the big tech ideas right now, right? It's very hyped. It's a field in computer science that uses machine agents to analyze data, make decisions, and communicate with humans. And all of it's written in code, it's processed by computer chips. So it's kind of everywhere. If you really think about it, there's a lot of little AI agents that help create this presentation and make this virtual thing happen. But it has serious limitations. So it's everywhere, but it's not this transformational thing, right? Not yet anyway. So the material constraints limit it, the math limits it, the hardware use limits it, and the biases and the limitations of its creators, as well as the industry pressure to make money and make the big next thing. I just want to say that a study produced by MIT recently showed that a lot of the major data sets that are used to train AI were riddled with errors that really called into question the performance benchmarks and the claims about some of the revolutionary possibilities of AI. So why did I mention AI? Because that's a big part of where behavioral health is heading. And fundamentally, it's a fantasy right now, and that's fine. Technology is always created based on fantasy, and there's good and bad. People can think of the Terminator or Rosie the robot from the Jetsons. And depending on who you talk to, a robot therapist could be either of those or both. But the truth is less fantastic, right? We're not able to totally replicate or produce behavioral health assessments or services through technology, though there are different components that are there. But slowly AI and behavioral health are integrating, and the more people use things, the more trends, the more data is produced, the more AI is going to be deployed. And a lot of private money went into behavioral health during the pandemic too. So I want to ask, where's the future taking us? One thing that I really learned in this project is that thinking about the future is best if you consider it complex and it's multiple, and you can't predict it or you can't determine it, but you can shape it. And to do that, you have to expand your thinking. But I do want to say with the future, we're not going back to a pre-telehealth period. Yes, we'll have resumption of in-person services, organizations will kind of stabilize, but you also have other entities and organizations and players and consumer norms that are going to change everything, and regulations that will get stabilized. So I do want to emphasize that the pandemic isn't over, that the behavioral health crisis that was before remains, and it's getting worse. And we're heading towards a future where more technology is going to be deployed as solutions to perceived policy and social problems. But technology solutions create their own problems, and we should think about that. There's a term that Meredith Brossard uses called techno-chauvinism to describe an ideology that if you give something like a task to a computer, it'll automatically be better, it'll automatically be more accurate. She's trained as a computer programmer and teaches data journalism at NYU. But often we know like the language of like data-driven means something, it implies good and better, but this is always the case. So I want to challenge that too, and I want to think for social workers and those of us who work in behavioral health in other ways, we're also consumers of technology, and even if our jobs maybe don't use it as much, we have skills and we have knowledge, and we're trained to understand these systems and see where these solutions fail or these attempt to tech things to fix it. And I think that we understand context really well, and I think we need to value that in our perspective in engaging with these things, and also embrace the possibilities too. So ways we can do that is to collaborate. There's certainly policy concerns. I think the biggest thing right now is pushing for permanent authorizations of telehealth. One really important bill is the Connect for Health Act of 2021, which has pretty strong bipartisan support. That's mostly about Medicare. But telehealth isn't really defined strictly, and the payment structure is so fragmented that there's not a uniform way to do it. But also what matters is a lot of the tech things. The Center for Connected Health Policy has really good state-by-state updates. So also you can check out different other groups that are going on. The Digital Mental Health Hub is a really good network. There are also online groups. It's interesting to see like Therapists in Private Practice is a huge Facebook group, and it's volunteer run, and they're talking about tech and like, what are they doing? What are they saying? We're all experiencing this. We can also continue to experiment, and I think we should research. I think we should refuse to say that, okay, things have to go back to normal, or that, technology is going to be taken away because of some claim that, okay, the emergency is over. So how do we navigate that, right? Are we embracing things, but also being critical what are we paying attention to? But really take the lessons that we learned from this experiment, expand your scope of thinking and your domain of practice, and imagine new possibilities. So I'm going to just click through my references. And last week, I did accept a PhD offer. As I mentioned, I'm incoming for the CUNY Graduate Center, and that really came out of this fellowship. So I'm really glad that I was able to do this. I created a Padlet, which is an interactive discussion forum. You can scan the QR code on your phone, or you can type tiny URL /NSWM Telehealth. I have a whole bunch of questions and stuff in there. If anybody has any thoughts, you can put it there, but it's going to stay up. I'm hoping people who see the video later will also participate. So thank you all. Thank you to the network again. I really look forward to your questions. This was a wonderful experience. And
Ian, before you get started on the Q&A, we do have Dr. Manderscheid on the line.
Yeah, good afternoon. I want to congratulate Ian on a wonderful presentation. Been delighted to work with him over this past year. I would say three things about the presentation. Well-grounded in what's going on in reality at the present time. Two, it spans fields. It spans between behavioral health and technology. So it's a bridging type piece of work, which is very important. And three, it begins to paint a vision and a picture for the future, which is absolutely critical. So when you put those three things together, you have a wonderful presentation. So congratulations, Ian, on the wonderful presentation. Congratulations on you're getting into CUNY starting next fall. Look forward to you being there and doing a wonderful job on your PhD, and look forward to you being in the field and working with others in the field to advance the field of social work. So kudos to you here.
thank you, Ron. It's been a real pleasure working with you as well. So I am just trying to answer some questions here. One question was about client engagement, and there is a lot of research. I read so much information about this. So I'm going to post some articles and links in the Padlet. I will again post the link to everybody. All right. And I see Silas asked, what can be done to thwart this reality, if anything? The thing is, I don't think we can thwart it, but I also think that we shouldn't fear change and we shouldn't fear technology. And I worry that often social workers, because we're so committed to our social justice values, right, and our human-centered things, that sometimes we're missing out on the power of new technology, or we're letting other entities define the future of that. So I think we have to really engage. And I think too, we have to look at the history of technology, right? Like big tech didn't always have the dominant presence in technology development. So there are other ways and other people, and I think we have to collaborate with technologists, with researchers outside of our domains or our specialties. And I think that's kind of where we have to go. I mean, that's why I'm going into a PhD, is I want to build this knowledge base. And I see that Jonathan Miller also asked, what are the implications for increased adoption of digitalization of mental health care for public and privatization of care? That's a really good question. I think we'll probably see, depending on the platforms that are developed, right? If private platforms with black box AIs and proprietary code are then implemented as like public health systems, and we do see that already. Like in New York City, there's a free 24-hour mental health crisis phone line called NYC Well. It's operated by Vibrant Emotional Health, funded by the city's Department of Health and Hygiene. They've gradually built an app library of these different kinds of platforms that people can use in addition. There are also contracts, that are going out to use Wobot or other types of apps. So I think it'll change in some ways the role of the clinician and the practitioner, and maybe in some ways that's good, because being an expert practitioner can also be very disempowering for the consumer or the user, and a lot of the times technology solutions can change that. And remember, doctors hated stethoscopes when they first came out. They were really threatened by them. So let's not be doctors hating stethoscopes.
Ian, this is Dennis. I have a question.
Sure.
The question I have for you is, how do you imagine integrating technology into social work training and education, part A. And then the second part of that question is, do you think in the emergence of technology as it relates to mental health, that the code should be open source to require transparency?
Would love to see the code be open source to require transparency, and for people to be able to adapt it. And in some ways, it's a similar question to the COVID-19 vaccines, right? Like lifting intellectual property protections of them makes them more accessible and more affordable. And we could say the same thing about pharmaceuticals. So any kind of tool or technology that has a human and public good, I think, yes, we should strive to make it open. I think in the economy that we have now, again, on one of my slides on big tech, it's a $10 trillion industry, or no, was it 5 trillion? And it's 10% of the GDP. It's very hard to fight that, but I think we can strive and we can work to do that. So actually, maybe that's one way to integrate technology into social work education, right? Is like do co-learning labs, with, I know USC, for instance, has a research center for artificial intelligence in society. But do more things like that are collaborating, that are exposing people to technology. And I think also be honest about certain degrees of workforce retraining, that depending on where people are in their lives with technology, but also don't treat it as this like thing, like you don't need to be the best programmer or know all the math to be able to work with and understand technology. We use and navigate technology every day. We all had to learn so much during the pandemic just to be able to do our jobs, just to be able to provide care for our clients, to finish our education. We should give ourselves credit, build our confidence with that, move away from this language of, oh, I'm not good with computers, I'm a social worker, because that needs to go.
Ian, thank you so much. Phenomenal job, very enlightening and very informative. And your calming, soothed demeanor makes it so much more palatable and less intimidating. Thank you, sir. Job well done.
Thank you. Thank you all so much. Now prepare to be blown away, because Lucero is going to blow me out of the water.
So again, as we continue to move along here, we have a particular cadence that we're working to keep. The next fellow that's up is also talking about technology as it relates to social work. And I want to just remind us that we use the Q&A that you can find located at the bottom pane. The Q&A icon is slightly left of center, and use the chat if you want to share your comments or make remarks about these really informative and well thought out positions on the issues that these fellows have brought forward. And it'll serve also as a source of encouragement for those of us who may go back and view our video one day, to have an ability to be able to see the comments that came up. So I encourage us to share our comments as well. Okay. So if you're just joining us, everything is fine. We're moving along really well. We're working to keep our cadence. Our next presentation will start promptly in about 2.5 minutes. We just want to make sure that we keep our cadence in the event that someone is logging in to see a family, loved one, or a colleague, to ensure that they get to see their entire presentation and not just part of it. And this is a lesson that we learned from the presentations that occurred last year. So thank you for your patience. All right, we're nearing a little less than about 1.5 minutes before Our next fellow presents her project. So as she is getting queued up, I want to ask you to fasten your seatbelts and get ready. The next voice that you'll hear and the next face that you'll see will be that of Lucero Huayhua. And I hope I pronounced her name correctly.
Hi, everyone. Thank you for joining us today. My name is Lucero Huayhua. You almost had it there, Dennis. I will be talking about effectively using client data to evaluate disparities in mental health service provision. All right, so let's get started. So as social workers in direct practice, we have the privilege and the honor to witness people's stories of and be part of their journey. We collect historical information, demographics, and document data from the individuals and their experiences. We really get a holistic view of the experiences and outcomes of children, households, and families. However, in macro social work, we only get a glimpse of the stories via these data points. The data that's collected on its own is only a digital footprint of the client's behavior. The assessment scores, risk scores, and also digital footprints of the person who is entering that information. By itself, data points don't really give us much helpful information. But data is a representation of people and groups of people, and that's why different entities in private and public sectors are using data that's available to them to create tools, identify trends, and make programmatic decisions that affect service delivery. In the healthcare system, we have moved on from collecting information in paper format to collecting information electronically. We're using electronic health record systems, software programs, and applications. They all help us record client information. I'll quickly tell you where the data goes when we entered it in an electronic application. Oftentimes, these systems record every click and word that is typed in by the person who is using the application. The digital footprints are stored in a database that helps keep client information secure, organized, and accessible. All the biopsychosocial information direct care workers collect from clients is stored in the system that makes it easier to extract data and analyze it. The process of extracting data can be done in multiple ways. I will be sharing how I've done this with SQL, since that's what I'm familiar with. SQL is a programming language that helps us communicate with a database. Even though there's a lot of data, we still may be missing pieces of our client stories. Some data is hard to capture, and also all data that we collect has a level of bias. After all, we're the ones who are designing the systems and the assessments that are collecting the data. When collecting information from clients, we have to incorporate a racial equity lens in the process and include multiple groups of people with different perspectives. This ensures that history and policies that have affected different groups of people are included in these stories. As social workers, we have to be part of this process and put at the center of data storytelling the voices, the stories, and the knowledge of our communities. This is how we're going to be able to use data for social good. create inclusive designs and recommendations for policy change. All right, so we have, we're constantly using data to explore and develop findings, make interpretations, strategize ways to reduce health disparities, and also draw conclusions about a particular problem or what is happening in our community or in a city. Our practice often informs the way that we collect data, the type of data that we collect, but data also informs our practice and the policies that get implemented because of the data. So it all goes in a cycle. One of the ways that we use data to inform our practice is by using it for evaluation. Evaluation also influences what type of data we collect. Some data we only collect for administrative purposes. Others is to fulfill a requirement as directed by a funding source, to improve service to clients, or increase efficiency of program delivery. Most often, we use it to evaluate programs and assess what is working and what is not working, and to ensure that we're providing quality services equally to everyone. Sometimes we do get lost in what is being measured and how much data we're collecting. In some cases, we collect more data than we know what to do with, or analyze data with no intent to drive action or change that may benefit the individuals who are coming to us for services. The data, which alone doesn't provide us with any specific information, once analyzed, provides trends that inform policy. Leaders and policymakers often use collected data to find patterns across multiple data points. It can help them better understand what is happening with a particular group, identify gaps and disparities in services, or help find the root cause of a problem and drive change in their communities. Recently, Client has also been used to create data-driven technology tools that identify clients' needs or progress, or tools that recommend a level of care, assess for risk. One way to use data is to create tools such as dashboards or KPIs. I will show you an example of a mini dashboard I created for a program that wanted to track the number of clients who didn't have any data in the race value field of their demographics, so that they could make an effort to collect that information when appropriate. And this is because the amount of unknown fields was higher than usual from other programs. So with a SQL query, I was able to extract that client data and provide what was needed. Please don't judge my SQL too harshly. I'm still learning, it's a process. This SQL query is basically a set of instructions. I'm giving the program a way to find what I need from the database. I tell it where to find it, what I need, and then it gives me a data set. Once we validate the data set, then we put this information into another application that creates the dashboard. So this is what you're seeing. We use Power BI, which is one of the Office applications. And I do, with this dashboards and KPIs, it really only shows the summary of what is happening, or it's only tracking a specific item. By like when we're looking at this alone, we don't really understand why we're looking at what we're looking here. The reason the diagnosis is there is because we are following up this diagnosis, particularly for this program, was interested in seeing the amount of people who had those diagnoses. So there's some context, there's some history. It involves talking to people in the community, members of staff, managers. We want to better understand the program demographics, and that's why we created this dashboard. I am aware that some of these applications, Power BI and SQL, may not be available to you, but this is what I learned to do with the resources that were available to me at work, and or that our team saw value and invested in them. And here's another example of how I'm helping evaluate or improve services offered in a particular program. So in this program, we knew the population makeup, and we also knew that there are some disparities in service utilization and diagnosis by race. So I started to look at differences in service utilization and narrow it down to the notes that document a diagnosis evaluation encounter. which is the service code 291, which we're seeing here. We found a few things, most notable, the average time that different groups have spent in this specific service was significantly different. Black clients had the lowest average in this particular service. And I also looked at the data by population, by ethnicity, and found that Hispanics share a similar experience where the average time that they spent is less than their counterparts. So this gives us a glimpse of what to strategize and do next to change the way that we're providing this service. This is just giving us information to the manager, to the program, to be able to take action. So we're still working on identifying the key factors and talking to frontline workers about the differences that we're seeing. And so I don't have other pretty data graphs to show you yet about the final product of that, but I do have a word cloud that uses the words in the notes of all the services combined. Here we can see the most common words in the notes. The bigger the word, the more times it was used. This is all exploratory process. From here, I can see the words that are used most commonly. So scheduling, appointments, rescheduling, and that opens up another conversation of what is happening for when clients are trying to get into services. So then I would go in and narrow down to scheduling appointments and see what's happening in the appointment section. The ways we use data and access data is changing rapidly, which is why we have to be ready for what's coming next and advocate for inclusive practices. Let's talk about the most common ways that data is being used to create new products. There's artificial intelligence, which includes predictive analytics, machine learning, natural language processing. The artificial intelligence piece uses large quantities of data and algorithms to make predictions about future events. And that specific utility is why we're starting to see more concerns being raised about the use of artificial intelligence in mental health and healthcare settings. It brings up the possibility that the models could be used disproportionately in a manner that heightens racial bias and stigmatizes or puts undue negative attention to people of color. Remember, we are the ones that are designing the products, and humans have inherent biases. Also, without full access to diverse data, the system learns from what is being currently fed. If there is current bias and racism in data, or the data doesn't accurately represent all populations, the artificial intelligence will simply reproduce what's already there. Another development is virtual reality, which is changing the way that we interact with our environment and also has the potential to create new intervention designs, as we see with a PTSD intervention being tested. The most common development with data is applications. We all use it. In mental health, there's been a high number of applications that have come up to support individuals with anxiety, depression, and more. The most popular one I found was WooBot, and it's an application, and the bot is trained with CBT theories. It's very exciting stuff. Also concerning data and technology have transformed our clients' experience in the public sector and healthcare. This is the beginning of a long journey that has the potential to use data and technology to improve the effectiveness of our work. But digitizing the public and healthcare infrastructure can also result in negative consequences and exacerbate disparities. So we have the responsibility to our clients to be involved in the design of data integration and data-driven technologies. It all starts with the data that's collected. Data integration is already happening is when we design a data infrastructure that allows for different systems to communicate with each other, which makes data by different entities easily accessible. Data sharing in government entities is fairly commonplace. And as we dive into more data-driven technology developments, we may start to see more data systems that communicate with each other. There's been multiple states who have successfully updated their data infrastructure. Here are some recommendations from the development across of cross-agency data integration. There has to be a clear purpose of creating that infrastructure. This helps people make decisions about who access the data, what data can be used and viewed, when and why the data will be accessed. Also, not all data must be shared just because it's there. Creating spaces for stakeholders to learn together and include frontline workers in decisions was another recommendation. People who are impacted by policies and by data sharing should also be engaged through the process and have a say in how their data is used. Keeping communities informed by sharing information and how data-driven tools are built and what is being built. Making analysis reports available to the public in different formats without all the academic or internal staff jargon. The last piece that still needs much research and dialogue is building processes for standards and protocols to who gets to access data and how we're developing these data-driven technologies. Regulation of data-driven tools and systems will become more common with the years to come, as we have collected so much data in this past pandemic year. So systematic changes are really can be difficult and feel that they're not tangible. So as I explored this new world driven by data and technology, I've learned a few things that I like to pass along. So together we can start to disrupt the current systems and drive changes in the future of service provision. The most helpful thing I've learned is to stay curious and keep learning. Coursera.com offers free courses for everyone. You can sign up and it's all online. You can also attend different workshops hosted by universities. They have different labs and institutes that are open to community members to join and in conversations. And another individual action you can take is share the knowledge. It's so hard to find information out there for macro social work. I encourage you to share what you're doing with everyone. Use the internet, Twitter, LinkedIn. I'm still getting better with that, but share and connect with others. Be present in the conversations that are happening. Thank you, everyone.
And Lucero, it looks like you do have at least one question primed for you.
Okay, let me go to the Q&A. That's a really great question. Has interoperability been further advanced since the mandate of EHR EMR? Yes, to an extent, but the process has been very slow from what I found in different research. It has, especially with government agencies, we all know some things can take a bit longer than we want to. So it's a work in progress, slow moving work in progress.
And Lucero, I actually have a question myself. First of all, I loved your suggested, courses that folks can do online and whatnot. But I've worked with a lot of social workers who just really shy away from anything related to data. So what do you say to those people, to those social workers, after learning all that you know?
Yeah, I mean, I think the first step is to be comfortable with technology as it is right now. So using technology and applications that are around us. So, like in my personal life, I incorporated Google Forms to keep track of my food intake when I wanted to create a different nutritional regimen for me. And, I use Google Forms because it was easy. I could access it on my phone, fill out the information that I had put in, and then quickly see, where was I eating enough vegetables? Was I eating enough leafy greens and things like that? So I think just getting started with getting familiarized with what is out there helped me become more comfortable and confident in understanding other applications like learning SQL, using Power BI and all of that. So I think getting comfortable is the first step, getting comfortable with what is available right now.
Can I ask a question too?
Yes.
Cool, because I can't seem to add the Q&A. I'd say, what would you say yourself coming as a social worker into learning the skills and the sort of technological literacy that you're demonstrating? Like, what do you feel is like your greatest advantage and like therefore the greatest advantage for social workers entering into that?
Yeah, I mean, I think as social workers, we really pay attention to that piece of the client's story. So when I'm looking at a database, right, like I'm looking at how can I find ways to help clients service the service that is being provided to clients. So there's always that piece of racial bias. There's always the piece of talking to people about those things, because sometimes it can be hard to have that conversation with a group of data analysts who are looking at data differently than you are. So it's really just a matter of having someone in the room who will ask the basic question that keeps the dialogue going. So just by asking, hey, why don't we change this to this? Or like, wouldn't it make sense to be more inclusive to have this instead of this wording? So just like very small things like that. I think as social workers, we have that unique lens that we bring onto the table so that we can start to question, why are things the way that they are? Can we change them? Can we improve them to make them more inclusive to everybody?
Thank you, Lucero. This is Dennis. I have a quick question for you. How difficult was it for you to teach yourself SQL?
I would say the process has taken about a year. So like starting into like getting familiarized with it. I started to talk to my friends who are engineers and kind of bouncing off ideas with them. I was like, how difficult is it for me to learn? And they're all very encouraging, and that's how I found resources, like where to go if I have a question. And also like sometimes bounce off ideas of like, hey, how do I do this thing? I have no idea where to start. And so just kind of going into Reddit and finding forums where I can ask questions for this, having friends that encourage me to learn. And more importantly, having friends who see the value of me knowing these skills, because they're like, yes, they're rooting for me, learn, go and like change the systems. And even getting them to think about the things that I'm talking about right now and incorporating into their work. So it's all like, yeah, it took me about a year or so to get better at it, at least to the extent that you see here.
Yeah, thank you so much. You did a phenomenal job. Your mentor, Linda, is not able to be here today, but we know how hard you've worked behind the scenes. You and I have had conversations, and I'm incredibly proud of the work that you've done and what you've been able to achieve given the things that were going on behind the curtain. So kudos to you. Keep up the great work. The way that you're integrating data into your practice through a social work lens, through social work values, is invaluable to the population that you serve, to the macro structure and the policies that you can impact at an internal level that'll one day, I imagine, be scaled, to a state level and possibly nationally. So thank you so much.
Thank you.
And as we get queued up for our next fellow, give a huge round of applause and thumbs up, clappy hands, emojis to everything that you've seen thus far. As you can see, there hasn't been any haphazard thoughts, that these presentations have been really thought through and they have taken deep dives. And we just want to make sure that we continue to keep them encouraged and inspired as they work to move what they've started here along. And just as a reminder, we want to use the Q&A for our questions. We want to use the chat for our comments that we want to share, or we encourage you to connect with the fellows or any colleagues that you may see in the attendees section. And just so you know, we are working to keep a particular cadence so that each fellow has the opportunity for their friends, family, loved ones, and colleagues to see their presentation at the scheduled time. And this is a lesson that we learned from our presentations last year. So this cohort has the opportunity of benefiting from our learning experience last year. So thank you for your patience. We'll be getting started. The next fellow will be up in roughly about a minute and a half or so, getting queued up. And while we wait, if you are here in the audience and getting involved in tech and learning how to code or learning SQL is something that you're considering doing or have been inspired to at least explore, put your comments down in the chat. I'd love to see who's actually thinking about how they can integrate that into their current work. So we're coming up on about 30 seconds before our next presenter. So you're going to, the next voice that you hear and the next face that you'll see will be that of Kate Gascoine. I hope I got the name right.
All right. Hi, everyone. My name is Kate Gascoine. I'm one of the fellows, and today I'm going to be talking about housing stability and some of the impacts the pandemic has had on that. So just to get us started, this is a brief look at what I'll be talking about. I don't work directly in housing, but I know how important it is for families and individuals to have stable housing, and also how important stable housing is for child development. So that's why I chose to look at it today. So to get us started, I just wanted to share this quote, and this came out of a provider meeting in my area. And as we go through this, think about the fact that it's not just one financial issue that these families and households are dealing with, it's usually multiple ones, and what type of impact that might have on them. So I am located in Allegheny County in Pennsylvania, so that's where Pittsburgh is if you're not familiar. The majority of our residents are homeowners, and I will say, like a lot of places around the United States, there's about a 30% gap between the percentage of how many homeowners are white and how many homeowners are Black. I also included the ranges you can see here for home values and median rent. This is data that came from our Department of Human Services, and they divided things out by census tracts based on low need areas in our community to extremely high need areas. So you can see based on where you live can really determine if you're able to afford to live there. We do have a housing continuum of care in our area. So DHS coordinates a lot of the housing providers, and that is everything from homeless services and shelters to people who do rapid rehousing and other types of housing programs. And we do have a coordinated entry system. So residents have one phone number that they can call if they do need help with a housing issue, and they'll get connected to an agency that can best serve them. And then our last bullet point here, are we a livable city? The Economist has regularly rated Pittsburgh as one of the top 3 cities in the United States for livability. So they base that on things like the access to and quality of healthcare and education. So Pittsburgh is going to rank very well for that because we are an eds and meds city. But it also looks at things like transportation, infrastructure, and housing. And if you work in the human services sector, you may really question if it's actually a livable city for all of the residents. We have some neighborhoods with over 60% poverty and over 60% unemployment. Gentrification in several of the urban areas has forced longtime residents out from the city core. They can't afford to live where they have been for decades, which also means they're being pushed farther from services that they need to access and even the ability to use the bus line to get around to their communities. And we still have some issues of de facto racial segregation in our community, quite unfortunately. And even before COVID, there were housing challenges here. About 14% of households had at least one of 4 major housing problems. So that can include overcrowding, the high cost of if they were owning or renting, and even a lack of kitchen and plumbing facilities. So might be livable for some, definitely not for others in our community. So during COVID, there were 3 big buckets of housing assistance that people could access that are on your screen here. A moratorium on being evicted or foreclosed on your home. There was financial relief for rent and mortgage, and then also looking at utilities, you could get relief for that, and also a moratorium on those being shut off. So these programs have drastically changed over the last year of the pandemic. Things have started and stopped at different times. There is also a big difference between local programs or county programs having different rules compared to what's going on across a single state or even across the country. So where you can afford to live is also drastically impacting what types of programs are available to you. So we're probably all very familiar with the eviction moratorium pushed by the CDC, which has been great for keeping people in their homes and helping reduce the spread of the virus during the pandemic. But it has not been accepted by everyone across the country, which I'll talk to a little later. There are also some safety concerns. I know there's at least one issue that came up in Allegheny County where there were safety concerns between different residents in a building and they weren't able to evict a person because local rulers said, no, there's an eviction moratorium, you have to keep everyone in place. So it was great in some instances, but not so great in other ones. There was also changing deadlines for when the moratorium was going to end. So if you think you're about to be evicted, and sometimes it's only a day or 2 ahead of time, and you're suddenly finding out that no, you can actually stay in your house a little longer, that's just causing lots of stress on residents in our areas. In Pennsylvania, we did participate in the first round of CARES rent relief, which again is great that we had an option for the people we work with, but it was a very hard application to get through, a lot of requirements. It required a landlord to cooperate. So if they didn't want to participate in the program, the tenant was not able to make use of that. Only about 1/3 of people got approved for that program in Pennsylvania. So with that first round of funding, a lot of money went back to the state budget. So it didn't get to the people who needed assistance. The later round that we're in right now is being controlled directly in our county. So they are able to provide up to 12 months of rent and utility relief, and that can be backdated going back into 2020 if someone does need assistance. And we also have an emergency assistance fund right now that a lot of local organizations are helping people get access to that, and it can provide small grants to third parties, and it goes beyond housing. So if you have a car repair that you can't afford to pay, you can ask for assistance with that, which means the money you would have spent on your car repair can still go back to your housing to help you be able to afford that. And then there's also been the utility relief, like I mentioned. At one point during the year, last year, applications for LIHEAP, which is the usual seasonal program to assist people with utilities, they weren't seeing as many applications coming in. So there's been a question of if tenants and residents are looking far enough ahead to what they're going to do when a shut-off moratorium ends, how they're going to be able to pay those bills. So this is just a quick look at what evictions have looked like in my area. You can see right about August, when one of the state moratorium ends, there is a huge spike in evictions that were filed, and it's tapered off a bit, but there is the potential that this is about to rise again when the CDC order ends in just 2 weeks. We've got about 1,300 open eviction cases I think that's just in Allegheny County right now. So 1,300 might seem manageable, but there's potential that can increase a lot more. But also at the same time, that means 1,300 people are struggling and unsure what's about to happen to their housing. So I appreciate that Haley put some levity in her presentation earlier because I wasn't sure how this little slide would go. But is this actually protecting renters at all? As you can see in the first bullet point from Eric Walter, there's no penalty if a landlord wants to violate the CDC moratorium. There's no barriers that are going to stop them from doing that. And fewer than half the states are requiring a landlord to prove that they're not violating something, even if they definitely are violating it. So it's not necessarily protecting the tenants that it is supposed to protect. A lot of tenants don't know how the eviction process works, and only about 10% ever get legal representation to help them through that process. So landlords are definitely taking advantage of this situation, which makes it very hard for tenants to get through. And I'm sure you've heard over several states, there are landlord associations that are suing the CDC over this because they want to get back to what business was as usual. And there have been federal courts that have supported the landlords over a lot of these regulations, which just mean tenants, again, are about to lose out on something that was supposed to protect them. And tenants and renters aren't the only people in trouble. Homeowners definitely are. They have been hidden in media a lot of the time because the rent relief has just been a bigger news issue. But when you think about that Allegheny County has a lot more homeowners, there's potentially a lot more people hurting there. This first bullet, you can see there is a massive increase in people who are unable to afford their mortgages right now. And this is a number that we have not seen since the Great Recession, which we all know is really bad for homeowners. So again, there's the potential that things are about to get really bad. And Black and Hispanic homeowners have definitely been hit hardest in this. They're a small part of all of the borrowers who have mortgages. But when you look at the numbers who are using the forbearance programs and the number of people who are delinquent right now, they're making up larger disproportionate shares of that. And when we think about homeownership is one of the ways to really build generational wealth for families. If these people are about to lose their homes, it also means their families are about to lose that access to something like generational wealth. So no matter if you are renting or you own your home, you also need to use utilities. And there's about to also be a looming utility crisis here, definitely in Pennsylvania, since that's the data that I looked at. But I'm sure in a lot of the states where everyone else is from, this is an issue also. We've got 1 million people who are at risk of losing their utilities because they're going to get shut off for the inability to pay. And you can see the massive increase in how much people have not been able to afford their bills. So having heard all of that, where do we go from here? So the first thing I think social workers need to be aware of and doing is advocating for public policies on a variety of levels, from the local to the state to the national. What is going to support your community the best? What is going to support the participants that you work with? And advocacy can look like a lot of different things. It can be going to a legislator and trying to work with them on a public policy that is getting enacted that's going to be really great for your community, or trying to stop something that's going to be very detrimental. But it can also just be educating people. Do your staff understand the policies that are out there that can impact their work and their programs? Do your clients understand what is going to impact their lives? And if you're in an area where voters can vote on something that is happening, are you educating the voters to have an understanding of that? There's lots of different ways you can advocate for housing policy, and it really depends if you want to look at the supply of housing or the affordability of housing. So if you're looking at affordability of housing, you can look for policies or bills that are out there that support affordable housing or workforce housing, or the expansion of something like housing choice vouchers. If you're looking at the supply side, are we supporting inclusionary zoning, which means that in a development, a certain percentage has to be affordable? Are we looking at stopping what is called exclusionary zoning, which happens in a lot of suburban areas? They don't let multifamily units be built, which also prevents then some of that more affordable housing from being put into an area. And there are also housing tax credits. So that can help a developer get a tax credit if they will build housing that's more affordable. It was really great in Pennsylvania. We recently had a housing tax credit approved, but then the General Assembly didn't fund it at all. So it's great on paper, we've got a tax credit, but in practice, there's no way anyone can use it because there's no money to fund what they need to be doing with it. Second point that I put here, I really think all of our staff need to be aware of what the policies are and how to advocate for them. You may not want certain staff being the people that go and talk to a legislator. Maybe that's your executive director or someone higher up in the program, but really everyone needs to have an understanding of what is out there that's either going to help or hinder their work. And then the last piece about providing supportive services and case management. If someone's coming to your program with a housing issue because they can't afford a piece of their housing, obviously, please help them with that. But at the same time, are we taking the next steps to maybe connect them to a workforce development program that can help them get better wages, a better job so that they can afford things? Or are we connecting them to other social services, like getting them to apply to SNAP? And then the money they spent on food can then get turned over to be spending on some of their housing. If your agency can't provide all of the services that people need, be willing to reach outside of your organization, stop the sort of siloing that happens in a lot of nonprofits. So reach out and build partnerships with other agencies in your area so that you can provide a warm handoff and it is better for the clients that you're working with. And then just some lingering issues of what we might see as we're coming out of the pandemic, whenever it finally ends. We're about to see a massive cliff whenever the moratoriums end on the foreclosures and evictions and utility shutoffs. The census has a pulse report. They've been surveying people throughout the pandemic. And in the last group of surveys that they did at the end of May, 33% of people said they aren't sure how they're going to pay their housing in the next 2 months. And I don't know about you, but I can't really fathom what that looks like when a third of the people in my county or my state can't pay for housing and potentially are suddenly homeless. And I don't know how social services are going to respond to that when there is that many people who suddenly can't afford housing and need all of our extra services. So we kind of need to start thinking now about what we're going to do when that happens. We need to be making sure we're taking those steps to connect people to all of the assistance programs that are out there, making sure someone can get the rent relief, get them connected where we can. And then also, I think we need to think about how are we going to rebuild relationships with landlords. You have landlords who have been suing. You have landlords that, especially smaller landlords who just have a few units in an area, they probably own mortgages on those buildings. So if they haven't been getting rent, they also probably can't afford to pay their mortgage. Are they going to be willing to work with our clients in the future? Smaller landlords tend to be, outside of the pandemic, have tended to be more willing to forgive late rent if that's the thing that happens. But are they going to be willing to do that in the future with our clients? So we really need to think about how do we rebuild relationships across a wide span of areas so we can help our clients. And in conclusion, I just want to say thank you for the network for letting me participate in this fellowship over the last year. And thank you to my mentor and the fellows that I worked most directly with, either my buddy or my group. You all are doing amazing work and I learned so many wonderful things. So thank you for this experience and helping me through it. And any questions from anybody at this time?
Hey, Kate, it's Todd. How are you? Hey, quick question. We never talked about this. The current infrastructure proposals, there's several of them. Do any of them have anything related to housing in them, do you know?
They do. So housing is directly listed, I know, in Biden's plans. And out of that, I know in the Senate, there is a current bill and there's like a partner bill that's in the House right now to support the expansion of opportunity housing choice vouchers. And there was another one that would talk, I think it's in the infrastructure bill, about funding home repairs. So for homeowners to make them more like energy efficient, generally doing home repairs, especially if there's like low quality housing stock in an area. So that is definitely a thing that's being talked about right now. So this is a great advocacy opportunity. People can look for ways to support those things, especially since there's bills currently in the House and Senate.
Great, thanks. Great presentation.
Thank you.
And Todd, while we have you, hi, this is Rain. Just curious if you wanted to provide any additional remarks. We have a little bit of time.
Oh, sure. I've been working with Kate for a while, off and on, following what's going on with COVID. And it's hard to estimate what's going to happen. I think, she did a good job of laying out everything that is being impacted related to housing and all the side issues that'll impact people. So, we still don't know, although it can't be good about what's going to happen in the near future. So I think it's great that this information is out there. We should get it out there more somehow to other areas besides just Pennsylvania. Great job.
Thank you. Yeah, thanks. I'm checking the Q&A, and Silas had a question about if I've heard of the emergency rental assistance program. So yes, at least in Allegheny County, this is what we've been referring to as the second round of the CARES Act. So this, it's controlled at least in Pennsylvania county by county. So what people in Allegheny County are able to do with that funding is different than some of the other counties in Pennsylvania. But yes, that's the 12 months people can access funding for renter utilities. So they can look at it going forward if they know they're not going to be able to pay in the next coming months, or they can go backwards 12 months to cover the rent or utilities that they hadn't been able to pay in the past. And then another question, what am I hearing about resources for homeless veterans populations? That's a really great question. And I will just admit up front that is not a specific population that I focused on with my work. I do know in Allegheny County, we have at least 2 agencies, I'm pretty sure, that do veterans work, including housing for them. So I do know there are social workers placed in those agencies that are making those connections to help people get into housing. And I think in general, sometimes how housing choice vouchers are structured, veterans have a way to sort of move up the ranks because they are veterans and served our country. So housing choice vouchers come with a lot of issues because there's not the supply though of housing to have people use them. But I do know that they have that opportunity.
I have a question. Katie. What would you say to, because I really like, it's a really great presentation. And I like that you also emphasize that advocacy and lobbying is not just kind of a one-off thing, right? It's not just times of budgeting or election cycle. It's really about getting involved in building those relationships. And I guess what would you say in a lot of social service organizations where there's a clear division of labor of who's seen as the ones responsible for it? What would you say to a manager or an executive to try to persuade them of the importance of even having line staff or clients involved in this kind of work?
I think the fact that, well, I think it's really important that clients participate in this because they're the people most directly dealing with these issues, and to hear from a constituent how it's personally impacting them and not just sort of this amorphous of oh, I have a client who did this thing. If a legislator can hear that very direct voice, I think that potentially matters more. So convincing your manager that these are the people, not that the manager doesn't know what's going on, but the people who are most directly dealing with it on a day-to-day basis can get that data of, I know my clients are dealing with X, Y, and Z, and using that sort of ground building work and then convince them that those are the ones who need to be involved also programs don't work if it's just one manager running it, so everyone should be involved. Yeah. All right, I'm not seeing any other questions, but if people have them, please feel free to drop them in the Q&A box.
Thank you so much, Kate.
Yeah.
Really loved your holistic approach in the educational component that staff need to be educated, the community needs to be educated, and getting people, educating the voting population. Really, really holistic approach. Great job. Thank you so much. As we get ready to move on to our next and final fellow for the day, I want to just remind us, if you have questions, you can please place those in the Q&A. You can find that on the panel, the lower panel, slightly left of center. And if you have comments, feedback, thumbs up, yays, can't believe the great work or anything, if you could place those in the chat for the fellow, that will be great. So we're coming up on about a minute before our next fellow and final presentation for the day. The next voice that you'll hear and the next face that you'll see will be that of Krenn. Give it just 1 minute here. Maybe a little technical snafu happening. Perfect. She's ready.
Hi there, good afternoon, everybody. So let me share my screen here. Can everybody hear me? Just making sure.
Yes.
Fabulous, thank you so much, Rain. All righty. Apologize, it's not, I don't believe it's allowing me to share my screen here. Oh, here we go, okay. Righty, thank you all for your patience while I'm working through the tech woes, as I've come to call them. So good afternoon, everybody. Thank you for joining myself and my colleagues on this exciting day of learning and information sharing. How fitting for me to follow Kate's wonderful work on housing stability. I love that Kate concluded with this call to action and discussion of the importance of advocacy. I feel like I am picking up the baton. So today I will be sharing with you my fellowship research on civic engagement in the housing insecure community. So a little bit about me. My name is Krenn. My pronouns are she and her. I am a licensed clinical social worker in New York and New Jersey. I work for Women in Need, or WIN, the largest provider of transitional and supportive housing services in New York City. I am a supervisor in a family shelter or a tier 2 shelter, and I lead a team of licensed social workers who address the mental health and substance use needs of clients in our shelter. Throughout my years at WIN, I have been in 2 of our about 14 locations now, one in Brownsville, Brooklyn, and one in Park Slope, Brooklyn. So I want to start by establishing some common language. Housing insecurity can mean an array of things. For the purposes of today's presentation and my research, we'll be discussing the sheltered homeless, this section here. Similarly, the term civic engagement can encompass many things. So for the purposes of my research, I invite you to think most critically about the political involvement component of civic engagement, and even further, voting, as voting is often seen as the essence of political participation in a democracy. So to get a little bit more specific to my work and research, I would like to share the daily average number of people residing in New York City shelters in 2020 was 58,591. With that being said, there was also 11,621 families with children residing in shelter as of 2018, when the most recent data was available. My interest and curiosity sparked about the intersection of civic engagement and housing insecurity during this past election cycle. In my conversations with clients, I learned quickly about the lack of information and disinformation about voting among the shelter community. Clients seemed to be unaware that they could vote, participate in the census, and more. Many clients assumed that due to their lack of having a permanent address, paying things like rent or property taxes, that they were unable to vote. This is not true, but quite frankly, an alternative was never presented to many of my clients. Today, every state in the country has a policy allowing people experiencing homelessness to vote, though there are still many obstacles to this population attempting to exercise that right, but more on that later. Activated by this, our organization decided to take action. I wrote a proposal and designed a series of civic engagement drives in our shelters. We partnered with the League of Women Voters to train staff on how to register clients as voters. We held civic engagement events in each of our locations. We registered people to vote, helped folks request absentee ballots, fill out the census, educate first-time voters. We held a book drive and hosted developmentally appropriate civic empowerment lessons for younger children. It was wonderful, but at the same time, it got me thinking, without the power and passion of a few already very overworked human service professionals at our organization, these individuals and families may never have been given this information or opportunity. So I dove into the data. Voting and other forms of political participation are skewed towards the elite, those with higher incomes, employment, and more education. Low voter turnout presents serious challenges to democratic responsiveness or the ability of leaders to respond to the needs and demands of citizens. When entire groups are left out of this process, how are their needs met or even heard? As we know, housing insecurity encompasses a lot of intersectional adversity, leading to the housing insecure population being boldly left behind in the democratic process. Looking at this history of voting rights for the housing insecure community, I learned that there have been many legal and legislative battles fought on this front for decades. Unfortunately, based on what I was hearing, none of these efforts resulted in meaningful ways to properly give housing insecure population a voice in the context of governance. Presently, we are seeing nationwide debate about voter protection as voter suppression efforts are on the rise federally and in various smaller government spaces across the country. So let's look into these numbers. According to recent data collected by the National Coalition for the Homeless, 60% of people experiencing homelessness are eligible to vote. And only 1 in 3 people experiencing homelessness are registered to vote, according to the National Law Center on Homelessness and Poverty. Yet, although there is little data on voting among homeless populations, research from the University of Southern California has suggested a voting rate as low as 10% among this population. Many political scientists have pointed out that despite free and fair elections, political participation and influence remain unequal and systemically biased in favor of the privileged. With this in mind, I tried to theorize some of the barriers to political participation in the housing insecure community, both concretely and allegorically. This included, concretely, transient residency, ID requirements in different spaces, transportation barriers, literacy and language barriers, and, as I was hearing in shelter, lack of information and misinformation. Allegorically, this included intersectional disenfranchisement, systemic exclusion, need prioritization, and as a clinician, I would be remiss if I didn't bring up at least one clinical theory throughout my presentation, so bear with me on this. Abraham Maslow theorized that when one's basic human needs are unmet or at risk, for example, when people are housing or food insecure, it is not possible for someone to focus on their hierarchical or psychological needs. For example, who is on the ballot or how someone's going to get to the box office in order to vote in the next election. The irony is, without the housing insecure community's participation in the civic process, we will never have elected officials in place who will make meaningful changes in the housing and food insecure space. But I digress. Other allegorical concerns are intimidation, devaluation and abandonment, and political distrust. So I ask you, how can the issues facing this population be addressed when the voices of the impacted go unheard? And this was the inspiration for my research. Let's loop in folks with lived experience and learn from their expertise. So I decided on a qualitative research approach that included participatory action research to clarify what this approach looks like for folks who aren't familiar. Participatory meaning collaborating with people with lived experience and empowering those participants to engage with the issue. Action, meaning real-time engagement, real-time problem solving, and solution-focused discussion about steps and interventions that can be operationalized. Research, new information gathered, new information learned, new information documented. As the research design continued, the project diverged into two pieces, and I partnered with my organization to utilize the expertise and resources I had available to me, both in the forms of clients and staff. I partnered with the policy and planning and research evaluation and strategic learning departments at my organization to hold insight groups in shelter with clients and staff. I then continued my research outside of WIN to include qualitative interviews with community stakeholders. So, what we learned from shelter staff. We learned that there is a need for greater focus on skill building for clients. This includes things like financial literacy and tangible trades, but this also includes civic engagement tools and skills. We heard a need for more training and supports regarding this matter for staff in shelter so that they will be able to, in turn, support their clients. In clinical work, we call this the parallel process. We heard that homelessness is getting worse despite more funding and programming. Programs seem to be designed to address individual problems rather than systemic ones, was something that we heard. Regarding the question of civic engagement, I understood this as it's not enough to have one-off conversations or events. We need systematic investment and intervention. We heard about a need to reduce the intake process and not to add to it with even more information sharing, even if we needed to get this information to clients. And lastly, we heard that overall, the system criminalizes and penalizes people for being low income or housing insecure. The system is not working for the people who need it, which sends devaluing intrinsic messages about societal priorities. What we learned from people with lived experience. We learned that clients largely feel unheard, excluded, forgotten, and intentionally left out of considerations about city planning, housing pricing, voucher pricing, etc. We heard about a need for shelter staff to be able to have the bandwidth to be more hands-on with clients, which is in direct opposition with the high caseloads and unrealistic productivity pressures often put on social service professionals. We heard the need echoed for staff to have more training and understanding of these matters to be able to educate people in shelter. We heard how education and empowerment are key. And lastly, throughout these groups, we heard the general sentiment of clients feeling like they do not matter to the government, elected officials, social service providers, legislators, and the list goes on. A term I heard multiple times, or a phrase I heard multiple times throughout these groups is, we don't matter. And what I learned from community stakeholders. I spoke with elected officials and their staff, candidates and their staff, community board members, traditional voter registration groups, and people with lived experience who had turned passionate advocates and public figures. I learned that there's very little effort specifically targeted at the housing insecure population. No elected officials or candidates that I spoke with have consistent, meaningful, and ongoing efforts in place to engage the population. They also often reflected challenges in holding the paradox of investing in the needs of the housing insecure population while managing the NIMBYism, or not in my backyard, portions of their constituency. I learned that traditional voter registration groups recognize the lack of engagement in this population and create small initiatives and projects to address this, but do not have the bandwidth to create robust voter registration efforts. In the largest city of housing insecure services in the country, New York City, I struggled to find an organization for voter engagement that was specifically geared towards this population, something that surprised me. In conversations with people with lived experience turned advocates, I learned that they feel the only meaningful and historically successful way to address a lack of civic engagement comes from community organizing, not systems level intervention or change. It was reflected to me that the systems simply aren't reliable, trustworthy, or authentic in their efforts. The work with the policy and planning and RESL team yielded a report geared towards advising the next mayoral administration on how to address and end family homelessness. It is incredibly robust and thorough, so I will not be able to go into all of it at this time, but it is published and available on the winnyc.org website. I encourage any and all interested to check out this roadmap and see the recommendations that came of these client and staff insight groups we held. While our WIN Client Insight Group team was creating this product, I wanted to collect all of the information that I had learned and begin to make sense of it. This ended up yielding a draft of a four-pronged model of civic empowerment in shelter, pulling on the philosophical theories of disruptive justice and community-rooted inclusion. This model aims at its core to invest in civic infrastructure in shelter by calling on partnerships and empowering clients and staff to feel like they have the tools and confidence to engage civically. So the first piece, education infrastructure. Information needs to be made available throughout the life cycle of a client in shelter, not just at intake and not just during election cycles. What we learned from the groups is that the intake process is so lofty, repetitive, and tiresome. To reduce intake fatigue and increase the likelihood that clients engage with this information in meaningful ways, this information needs to be shared and made available regularly. Then, of course, revisited at the time of elections, likely in the form of civic engagement drives internally and with voter registration group partners. Another key component to this is partnering with traditional voter registration groups and others to provide the much needed training to staff so they feel prepared to have these conversations and best support clients. The second piece is building community power. This centers around valuing and empowering community expertise, encouraging community members turned advocates to be a part of the information sharing and spreading process. This is extremely valuable because having people sharing this information reflect the cultural and experiential identities of the shelter community is key. This hopes to secure buy-in from clients, build trust in the system, sustain investment so that clients, sustain the investment that clients do feel once they're pulled into the process, and support an idea exchange and information sharing about how to best use one's voting capital to meet the needs of their family and the housing insecure community at large. The third prong is stakeholder investment and collaboration. This needs to be cross-sectional stakeholder investment to reshape the intrinsic messages that clients receive about their value and worth as constituents. We need to pull in electeds, organization administration, local community boards, and beyond. Any stakeholder with institutionalized power to shift policy and practice should be called into this process. This can look like drop-ins, holding town hall style talks in shelters, attendance at community meetings and other shelter events, graduations, for example, at this time of year, or any other creative engagement opportunities one can think of. Anything to bridge that gap and help connect community power to civic and social capital. And the fourth prong, investing in the concrete logistics of getting civic engagement accomplished, providing access to transportation or compensation for transportation to the polls, both in early voting and on election days. For example, providing clients with a Metro card. Another way this shows up is supporting clients with access to absentee voting, whatever it takes to make voting possible and seem possible for clients. Without these core final investments, we can find ourselves in a circumstance where knowledge is shared, community is built, investment is made, but access is not granted. I will be continuing this research next year in my doctoral studies at New York University, where I hope to keep tinkering with this model, develop it further, and move into a phase where it can be peer reviewed, regarded as evidence-based practice, and implemented in shelters in NYC and beyond. The democratic process should produce an outcome that captures the general will of the citizens. When entire groups are left behind or intentionally excluded, this can never be achieved. By restricting or gatekeeping information about the voting rights of the housing insecure, society keeps individuals experiencing homelessness in their disadvantaged position, preventing them from reaching greater heights as political participants and citizens at large. Moreover, our society is not whole without the consideration of all. My goal is for the vote of the housing insecure population to be sought after by candidates, and for its influence on policy and society to be meaningful and monumental. I hope this research plays some small part in moving towards making that a reality. Finally, I want to profoundly thank my WIN team, the Network for Social Work Management, my mentor, Dr. Marcella Wilson, my buddy Bree, my awesome small group, and my incredible friends and family for all of their support throughout this project. Thank you so, so much. And thank you to all of you attendees today for your time and attention. If you would like to discuss any of this work further, please see my contact information here. After a couple of seconds, I will dismiss this slide and invite any reflections or questions about this information. Questions are always welcome, as are reflections. What came up for you as you heard this information? Do you feel called to be an advocate? If so, join us. Voting is power. Thank you so much.
Wonderful. And it does look, Caitlin, like you have a question in the Q&A. I'm happy to read that unless you're looking at it as well.
Okay. So I see Silas asked, are local elected officials, especially social workers, on board in making sure that right is available to this population? So making sure that the right to vote is available, Silas, I just want to make sure I'm answering your question. If that is the case, the answer is yes, based on my conversations. Yes, in theory, but as I mentioned, it was very interesting. It seems like a lot of elected officials hold this paradox where they balance the needs of all of their different constituents, right? And unfortunately, the housing insecure population does not have a lot of social capital, right? So the counter to that, which is organizations that kind of buttress NIMBYism efforts or not in my backyard efforts, oftentimes those kinds of groups have a lot of social capital. Those are people who live in wealthy neighborhoods who are pushing out the housing insecure population. So if you are a sitting city council member or something of that variety, supporting the housing insecure population could have political consequences for you. So I spoke about with community stakeholders about how complicated it is for them to hold that paradox. And I think it depends on the official, quite frankly. But largely, many folks are in support of this, Silas. But getting people to really invest in meaningful ways, that's the trick. I hope that answers your question. I know it's a very nuanced answer, but it's a very nuanced question. So.
Hi, Caitlin. This is Dennis. Great job. Very thorough. Thank you so much. I do have a question. Of the over 58,000 people who are housing insecure or listed as homeless, was there any data that indicated what percentage of that population are actually employed full-time?
Are what? I'm sorry, of that population that are actually, you cut out there. Sorry.
Employed full-time.
Employed full-time. So that data is available. I could look it up for you. And so I'm not sure what it is off the top of my head. I do know, however, that it's also been complicated with something that I didn't really bring into my my presentation, but it is the backdrop of the world that we're living in, is the state of the world and the economy and our public health concerns. And so unfortunately, the number of unemployed folks in shelter has gone up. So I'd be interested to see what those statistics are going to look like with even more recent information coming out. But what we are anticipating also is a huge uptick in homeless services in the near future because of the economic downturn and the housing crisis, that when eviction moratoriums are lifted, we are anticipating seeing many, many more people coming into shelters because of folks losing their jobs and beyond, and much more complicated and nuanced factors as well. So Dennis, I'd be happy to get that actual number for you. But it's gonna be pretty significant if it isn't already.
Right. Thank you so much. Great job. I don't see any additional questions down in the Q&A. I don't see anything in the chat. I wanted to, number one, just say that you did a great job. Your mentor isn't able to be here today, but I know personally how this undertaking, I remember when you first started and how ambitious and naive you were, thinking, I got this great idea, they're gonna let me do it. And all of the obstacles and the hidden barriers that you came up against that required you to adapt and to make adjustments and to change your strategy and approach to having these conversations with the stakeholders and the different departments within your employer, and recognizing that everyone's not happy to see this and everyone's not on board. So I'm really incredibly proud of what you've been able to accomplish, given all the hidden barriers and obstacles that you had to jump over. I mean, flaming hoops and water in hand to douse the water. So I'm really incredibly proud of what you've been able to accomplish. And secondly, congratulations on your accepting your offer to your doctoral program. This work is certainly what's needed. So we are incredibly proud of you, and you brought us home really well and strong today, along with your colleague, Kate, in the housing industry, and how social workers are actually doing work that's meaningful without compromising our values in serving this population. So thank you so much, so much. We really appreciate it.
Thank you, Dennis, for your kind words and for all of your support.
Yes, and what we're going to do now is we're going to ask all of the presenters from this particular segment to come up on screen to take any final questions that the audience may have. So if you can come up on camera, that'll be great. Thank you.
And we can also field any comments, reactions at the end of the day for those of you who presented. Wonderful job. But again, any comments, reactions, and or questions. And I guess I can kick it off. So this goes to our fellows. How do you feel now that you've completed your presentation, and what are you most looking forward to as you move forward?
I'll just get us started. I'm happy that my presentation was done. I was very anxious all day. So that's exciting. The Providers Council that I work with in my new job is also talking about what are we going to do when moratoriums end. So I will be continuing this conversation next week with those providers.
I guess I'll go. I'm also similarly happy to have finished it and got it in under 15 minutes. And I saw in the chat, I had invited some people from work and other parts of my life, and they came, and I was really pleased that they joined. Also really pleased to see everybody else's work. I'm really impressed and honored to be a part of this group. And in terms of looking forward to, I'm finally taking an actual vacation that will not involve any remote work or any academic research or meetings with professors or random other people who I'm trying to connect with in the first week of July. And I'm very excited about that.
I am very glad it's over, only because I seem to struggle with that tongue-tying situation, and then I get nervous, and everyone said, well, that's just how things happen. But Caitlin was absolutely flawless. I was so impressed with how she was so on task, and I think everybody did a great job. I think that the technology issues we deal with, but I think helping to forge a future path where we're looking seriously at substance misuse and mental health treatment is my path forward, and what I'm looking to try to do with this position here at the health department.
Wonderful. And I think we may have some of our other fellows who are up to present tomorrow. They have been unmuted in case they have any questions or want to make any comments.
Well, I just want to say that all you guys did a terrific job, and boy, what a tough act to follow, man. After all you guys, man, we have to go back to the drawing board, and we only got till tomorrow. But no, in all seriousness, everybody's presentation was very inspirational, very informative, and and being the journalist that I am, I heard a lot of really interesting points that I'd like to at some point maybe circle back around and talk to you guys about, because a lot of timely issues, but great job. But like I said, the pressure's on now, so thanks a lot, guys.
I would have to definitely echo that, Silas. This is Terrell, and I've been live tweeting throughout the day for you guys. So amazing presentations. I am completely stunned, and I thought I had everything I needed in my presentation. I'm like, well, good for us that we get to share our screens tomorrow and not today. But no, it was flawless, and you guys are amazing. I'm so proud of you all. And then if you haven't, put your contact information in the chat so everyone else can follow you guys on social media and LinkedIn and stuff. So
I will jump in and just echo what I already put in the chat. I just want to say congratulations to all of you. I have been glued to my screen this morning, just holding on to all the information that you all have presented. I'm feeling really inspired and motivated by all of your work. And I just really wanted to say great job and great work this entire year. Let's continue to build on this work. Let's continue to partner together and support each other in the work. And congratulations, go celebrate now. And we'll be able to join y'all tomorrow.
Wonderful. Well, we do thank everyone for your participation today. I know we still have a few attendees who are, outside of the Policy Fellows Program Network. And again, just appreciate you taking the time. And I hope, as I did, that you are leaving with a lot of great nuggets, and really that this piques your interest for future exploration. And definitely want to make a plug for each and every one of our fellows that keep your eye out for what they are going to accomplish in the future. And this really is so inspiring to know that our social work profession is in such great hands. And with that, Dennis, any final thoughts?
I don't have any final thoughts. I just smile because I think about the first day when we had our orientation and I said, life is going to happen. It's going to happen in real time. And you're going to be proud of what you actually produce. And just encouraging you not to get bogged down into the details, but to step back, take an overarching view and then drill down from there. And to see what's come out of this process is nothing short of amazing. And I'm just happy and I'm proud. It's just a moment of reflection. Can't thank you enough for inviting me and Rain into your spaces to be a support as your fellow alums who actually went through this process at the beginning of the pandemic. So just thank you all for trusting us and trusting the process, and congrats.
Great. And so we will ask the fellows who presented today to stick around for a little while, where we want to make sure we're memorializing this with a photo in Zoom fashion. But for everyone else that, again, joined us today, thank you for your time, and please enjoy the rest of your day. Take care. Okay, Brianna, we'll go ahead and have you stop sharing, and then for who knows how to do this best in terms of taking a picture. Lakia and Brianna, actually, are you available to jump on camera? We can get one with all of us and then just the fellows.
Let's stop recording first.
Thank you.